Good morning.
Hello.
Hey, yes, been watching. How are y'all?
Good morning.
Good morning. Nice to meet everyone.
But we will get started in a few minutes here.
We're here for the study committee on improving family caregiver services, and we have two senators, I believe, one on Zoom, which is Senator Ben Watson. We also have Senator Kenyon Wicks here at the Capitol, and we're going to be starting today with an overview of different programs. We have Catherine Costanza, Glenn Jacoby, and Joe Livingston, all with the National Conference of State Legislatures, and I believe the first person we'll be speaking is Catherine Costanza. Thank you.
Thank you so much, Chair Jones, for inviting NCSL to join today. Can you hear and see me okay?
Yes.
Excellent. I will go ahead and share my screen and we'll go ahead and kick off. All right. Slide deck coming up.
Yes, it is.
Okay, excellent. We'll go ahead and get started. So again, thank you so much to Chair Jones for inviting the National Conference of State Legislatures to speak today. My name is Catherine Costanza, and I'm with NCSL's Health Program, and I'm joined by my colleagues Joe Livingston and Glenn Jacoby from NCSL's Fiscal Affairs and Employment, Labor, and Retirement teams, respectively. And just in time for National Caregiver Month, today we'll be providing an overview of family caregiver policies across states. And briefly, before we jump in, if you aren't already familiar, the National Conference of State Legislatures, or NCSL, is your nonpartisan and bipartisan professional membership organization. So we provide all the services listed here on this screen to the over 7,300 legislators and over 20,000 legislative staff in all 50 states, DC, and the territories. So if there are any follow-up questions that you have after this presentation, please don't hesitate to reach out. It is literally our job to serve you and the state legislative work, and our contact information is at the end of this presentation.
Thank you.
And with that, I'll go ahead and dive right in. So we've been asked today to speak about the following 4 topics related to family caregiver policies, specifically paid family caregiving, family support services, tax credits, and paid family leave. And with that, we'll dive right into paid family caregiving. So to start and provide some context, who are unpaid caregivers? Well, 1 in 5 Americans provide unpaid care to another person. This can include an individual with sickness, disability, or other activity restriction. And half of caregivers of older adults are specifically caring for someone with Alzheimer's or other dementias, which we know can come with its own unique challenges. And caregiving is also hard work, with 1 in 4 caregivers reporting negative health impacts from either the physical, emotional, or financial strain of caregiving. And that's where family caregiving policies in states come into play. So when we're talking about paid family caregiving, Medicaid is often one of the places that we look to for state policy. As the only public payer of long-term services and supports, including care provided in homes and communities, Medicaid plays a significant role in paid family caregiving. And when we're talking about paid family caregiving, what we're specifically talking about is paying the family or relative caregivers for covered benefits that the caregiver is providing to the individual who is a beneficiary of that health coverage. So in this case, a Medicaid beneficiary. So when we're talking about Medicaid policy, it can be very easy to get lost in the weeds. So we're not going to dig into everything on this slide in detail, but I want to highlight the 3 buckets of state policy choices that states can make when they are thinking about paying family caregivers through the Medicaid program. And these include program authorities. So what is the program authority you will choose to authorize paid family caregiving? Mostly these are differentiated between a state plan option, which is available to all Medicaid beneficiaries statewide, or a waiver option, which is available only to a targeted population, usually through Section 1915C or Home and Community-Based Services waivers, where they may only be available to individuals with disabilities, older adults, or certain children with certain health needs. Additionally, some program authorities come with different federal matching rates. So for example, the Community First Choice State Plan option comes with a 6% federal match enhancement. The next proportion of Medicaid paid family caregiving is how states define benefits. So all home and community-based services are optional, so states can choose which benefits to cover and the scope of those benefits. And the benefit and how that's defined is what the family caregiver is paid for and the scope of the services that are covered. So this can include personal care services, which can include activities of daily living, which are and include services that are ordered by a doctor, provided under a documented plan of care, and supervised by a nurse. States can also provide state-directed services benefits, which include a budget dispersed directly to the beneficiary, and the individual can then direct their services. And under this, beneficiaries can hire their legally liable relatives, including parents and spouses. The family CNA model trains and reimburses family members to provide certain types of low acuity in-home care that are supervised by a registered nurse or a licensed practical nurse. And family supports we're going to talk about a little bit later, but this can include other covered benefits like respite, home modifications, assistive technology, and more that can indirectly support family caregivers, even though they are a benefit to the Medicaid beneficiary themselves. And then the third kind of bucket of policy choices that states can make have to do with eligible providers and services. So which family members and services are eligible for payment through the Medicaid program. And we're not going to dig into this in detail because it's incredibly complex and legalistic. But both federal and state law will define the scope of which family members are eligible to provide services and the types of services that they can provide. An important distinction that comes up frequently is the difference between legally responsible individuals. So these are individuals like parents of minor children or spouses who would otherwise have a legal obligations to ensure that their family member is cared for in the absence of a paid benefit. And then other relatives, so non-legally responsible individuals. And in some cases, legally responsible individuals are only eligible to provide what's considered extraordinary care. And again, these are defined in both federal and state law and are very state specific. So when we're looking at paid family caregiving in state Medicaid programs, 22 states use any state plan option to cover both legally responsible individuals or other family and friends in paid family caregiving. 49 states and DC will reimburse any family caregiver through a waiver. 46 states and the District of Columbia permit beneficiaries to direct their care, including purchasing services directly from their legally responsible individuals and family and friends. And 10 states, including Georgia, have a structured family caregiving benefit under which the caregiver is paid a per diem, usually through a overseeing structured family caregiving agency that helps provide education and training to the family caregiver as well. I'll also point out that states can choose which populations are eligible for paid family caregiving, predominantly through waivers, with the vast majority of states paying family caregivers for individuals with intellectual and developmental disabilities, older adults, and individuals with physical disabilities. And some more of that information is provided through the KFF family survey that's provided on this slide. So what are some state examples of paid family caregiving? Well, since 2023, at least 8 states have extended Medicaid payments for family caregivers beyond the public health emergency. So during the COVID-19 public health emergency, many states were given temporary flexibilities to pay a larger scope of services or more legally responsible individuals who are family members for services provided to the Medicaid beneficiary. And these 8 states have chosen to extend those payments beyond the public health emergency. We've also seen states enact and then amend legislation related to paid family caregiving, with North Dakota being an interesting example. So North Dakota established a family caregiver service pilot project in 2023 to pay those legally responsible individuals through their home and community-based services waiver for certain types of waivers, but they did exclude others. And in 2025, they amended this program specifically to exclude payments when care has been provided or otherwise compensated through a different Medicaid benefit. So essentially just ensuring that the scope of services provided is not being duplicated across the Medicaid program. And New Mexico also established a 3-year kinship caregiver support pilot program this year that refers its participants to monthly economic support programs and provides other types of service referrals. So that's a brief whirlwind of the paid family caregiving landscape. So what about family and other financial supports? So when we're talking about family supports, these are supports that they're not a benefit to the beneficiary, they're a benefit to the caregiver directly or indirectly. And these can be provided either through the Medicaid program or through state-only grants, fundings, and appropriations. And these can, so the definition for family supports I've taken from the State of the States of Intellectual and Developmental Disabilities, which is a project of national significance that tracks state spending and fiscal effort on services and supports for people with intellectual and developmental disabilities. And family supports can include, again, either Medicaid or state funded financial subsidies to families or other supportive services such as respite care, family counseling, equipment, architectural adaptation of the home or home modifications, parent education and training, or other types of state designated categories of family supports. So these can include support for the caregiver themselves, such as subsidies for respite care, adult day services, counseling, or support for health coverage. So we've seen both Illinois and Florida make some changes to permit caregivers to access health coverage more easily by disregarding the income they receive for providing caregiving services. Services and supports can include education and training so the caregiver feels confident delivering services to their family member. Community transitions may include programs like the Medicaid Money Follows the Person program, which provides temporary and time-limited supports for 1 year and no longer to facilitate transitioning individuals from institutional settings and back into their homes. And it can include a lot of the services listed here. And then there's supports related to the costs of care. So these are financial costs that may otherwise be assumed by the caregiver to provide caregiving services, such as home modifications, access to equipment or assistive technology, legal and financial services to ensure that the individual has appropriate medical decision and financial decision making, and transportation. And then state funding. I'm only going to be talking briefly about some of the grant and subsidy programs, but you'll hear more about tax credits and about paid family leave policies from my colleagues. So I'm going to very briefly cover a couple state examples of what family supports might look like. So in 2020, Arizona enacted legislation to allow caregivers to receive a 50% reimbursement up to a $1,000 cap for home modifications to make living spaces more accessible and to cover assistive care technology as well. It also provided other direct care services, including individual counseling, respite care, and informational supports to the family caregiver. I'll say that this program launched in 2020 after a one-time $1.5 million appropriation from the legislature, but it did automatically sunset under the terms of the original statute on July 1st, 2023, and the program's no longer taking applications. Next, we'll move to Maryland. So just last year, Maryland established the Caregiver Expense Grant Program through the State Department of Aging. And this awards grants to certain caregivers for certain qualified expenses paid or incurred to provide care to their family member. And it covers up to 30% of qualified expenses that exceed $2,000 or more. So the family member is still responsible for services up to $2,000, but this program will cover up to 30% of costs above that. And qualified expenses include home modifications, the purchase or lease of equipment, employing a home care aide, and costs for adult daycare, specialized transportation, assistive care, or legal and financial services. And this appropriated up to $5 million in the program annually. And interestingly, in the evolution of this bill, it was originally structured as a tax credit, but then revised it into a grant program over the evolution of the bill. Pennsylvania also established a primary caregiver support program to assist persons who bear primary responsibility for the at-home care of certain individuals. And it permits the Area Agency on Aging to reimburse qualified caregivers up to $200 a month for out-of-pocket expenses and up to $2,000 of a lifetime limit for home modifications or assistive devices. Although, interestingly, the agency raised these limits up to $600 a month and up to a $5,000 lifetime limit shortly after enactment. And it includes some protections in the bill as well. And then finally, and very quickly, the Katie Beckett program in Tennessee provides Medicaid benefits for children who are ineligible for Medicaid directly due to their income. And Tennessee has structured their program into two parts. Part A is the traditional Medicaid benefit, but Part B is funded through state-only dollars for children who are at risk of institutional care but don't actually qualify for Katie Beckett benefits. And what it does is it provides up to $10,000 annually in services that families can choose from a menu of options. So that up to $10,000 annual budget includes flexible funding for respite care, home and vehicle modifications, a debit card for qualifying medical expenses, assistive technology, decision-making supports, family caregiver education and training, family-to-family support networks and access, and health insurance counseling and assistance. And with that, I will pass it. Here's more information on where Georgia fits in terms of the larger national context on paid family caregiving and family supports. And I will pass it over to my colleague, Joe Livingston, to discuss tax credits.
Thank you so much.
Thank you so much. And thank you all for having me today. Yeah, I'm thrilled to talk to you a bit about the tax landscape and a very different way of targeting the needs and supporting families. We're going to focus on a variety of different credits and exemptions, and a lot of these are focused for children, but some are also available for other dependent needs. So first, looking at the state child tax credits, I would classify this as kind of the most simple to understand and the most basic for taxpayers. And these are credits simply for having children. They can have income thresholds. We've seen in some states phase outs can start at $29,000. We see that an example in Minnesota, all the way up to, in certain cases for joint households, all the way up to $400,000 in Maine. And the amounts of these credits can vary wildly. So all the way from Arizona, where there's a $100 credit, to Minnesota, up to $1,750 per credit. And in many cases, the higher credits and states that issue the higher credits are also phasing out at a lower level. So they're pairing it and really trying to target this towards lower income brackets to give the most amount of support. The refundability issue also varies. There's non-refundability and variance in a variety of states, and some states like California, Massachusetts, where these credits are fully refundable, again, with that targeting of the sort of lower income families at the heart of that. And on the next slide, we'll talk about a few other examples. You can see kind of the state map of where these are refundable and non-refundable. They're available in 20 states. And again, we're talking about state level tax credits, of course. These are separate from the federal ones, which we'll talk about in a bit. In 2025, there was a variety of new legislation. In Georgia, the new $250 credit per child under age 6. In Maine, doubled the credit for kids under 6, lowered their threshold. Maryland, they removed the eligibility cliff, and now it's available for incomes all from 15 to 24. New York increased. Utah expanded the qualifying age, and Vermont expanded the qualifying age as well. So a lot of tinkering going on in the states, and in some cases, brand new credits being introduced. Next slide. Another way of targeting this is tax credit of supporting families and encouraging families to work is supporting tax credits for childcare specifically. And so in 26 states plus DC, there is some kind of child and dependent care tax credit. And again, the refundability and income scaling varies. In New York, we can see the refundable credit of up to 110% of the federal credit. And we'll talk about the federal credit in a minute so you can see kind of how that would work in tandem with that. In Alabama, the child care credit covering 50% of costs. Minnesota, up to $1,200 per child. Again, sliding scale by income. Colorado, up to 50% of the federal credit. Oklahoma, non-refundable child tax care credit up to 20% of the federal credit. And so again, these vary significantly in terms of income thresholds, in terms of how much support they're going to be giving. And in many cases, they are tied and to the federal limits. So that conformity issue, which we're seeing in a lot of other tax areas, also comes into play when we're speaking about childcare. Next slide. Dependent exemptions work a little bit differently. Some sort of like a credit, but not in exact dollar amounts, but each state will define how much each exemption will reduce taxes. The federal exemptions are no longer in place, but a variety of states keep those exemptions or have put in exemptions. So we see in Indiana, $1,000, Virginia, $930, Illinois, $2,850. And some of these states are converting exemptions to credits. So the thought being that everyone would be entitled to an exemption regardless of income. Does it make more sense instead to simply use the credit model, which can have phased in income thresholds to more specifically target lower income families? On the next slide. So a different way of supporting families, instead of focusing on the taxpayer itself, is to focus on the employer. So this encourages employers to provide childcare through corporate tax credits or deductions. And there's at least 17 states that we're aware of right now that are offering these. Some of these are employer match programs, some of them are donations, and some of them are property tax exemptions, depending. And some of this will support, on-site care. It really depends on the state, the specific eligibility and what they're trying to cover. But it can cover things all the way from facility construction to contracted child care services and operations. We see a few recent examples in the last few years that have been put into place. Alabama, a credit of up to 75% of employee-incurred child care expenses. Florida up to 50%, and New Mexico 30% with a credit cap of $30,000 per year. So there typically are limits, and for smaller businesses, those limits can be quite significant in the impact for the business itself, and can be extremely helpful to the family when employers actually do go down this road and take advantage of these credits. And then on the next slide, I know you were all asking about the Nebraska Caregiver tax credit. So then we see yet another way, and this one we're focused on dependent care this is not a child-focused one, this is for other dependent care. But in Nebraska, they did something pretty interesting this year by doing a non-refundable credit for family members needing help with 2 or more daily living activities. Again, there are income thresholds, 100,000 joint, 50,000 single, but it's high enough to support quite a few individuals in Nebraska. And that non-refundable credit covers 50% of eligible expenses. And you can see the caps there, $2,000 or $3,000 in the cases of veterans or dementia care. And it covers a wide base of support ranging from home modifications and durable medical equipment to others. And it has an annual program cap right now of $1.5 million on a first come basis. So we'll be watching Nebraska closely to see how much this program is taken advantage of and whether there down the road are tweaks to expand that base. And on the next slide, I'd be remiss to talk about the state level tax credits and deductions without noting the significant changes in the federal landscape, which I think you're probably well aware of, but just to kind of go over what those are. HR 1, the One Big Beautiful Bill Act that was passed this year, did put into place quite a few significant changes. The first one being the Child Dependent Care Tax Credit expands starting in January. Now it's up to 50% credit for low income families. Same expense caps and 6,000, but it remains non-refundable. But for families that do qualify, that'll be a significant impact. The DCAP limit is now $7,500 and remains non-refundable. And a big one, it's not a massive change in number, but this number has been fixed for quite a while. So seeing it raised at all is sort of a big deal. Child tax credit increased, raised to $2,200 per child under age 17, and it's now indexed to inflation. So what was previously a fixed amount where we weren't seeing any increases and had to continue discussing this every year, now we're going to see this pegged to inflation. It remains not fully refundable, and it excludes families earning less than $2,500. And then finally, the dependent care FSA, the federal flexible spending plan for employees. Most employers do offer these. And many families do take advantage of these dependent care FSAs. The limit, which was long held at $5,000, jumped to $7,500. And these can have a pretty big impact because for states that are conforming or use the adjusted gross income from the federal level to trickle down to the state level, AGI, potentially that additional 2,500 is now not subject to federal tax, not subject to state tax, and it's FICA reduced as well. So for a family in a 22% bracket with a 5% state tax, you could be looking at 35% off of that $7,500 of care. So these programs do make a big impact. And I put all of that out there on the federal side to make sure that those are considered in the overall context of state level changes, which can complement these in a variety of ways. So with that, I am going to turn to our final segment on family caregiver policy landscape with my colleague, Glenn.
All right, thank you.
Thanks, Joe. Hello, I'm Glenn Jacoby. I'm a policy associate with our Employment, Labor, and Retirement team, and I cover paid leave issues for NCSL. I do just want to note we are going to be focusing today for the sake of, I know we have a lot of speakers on these top two categories, mandated paid family and medical leave programs, as well as voluntary paid leave insurance options. But there are a few other trends that we've seen in the last couple of years in the paid leave space. And so if anyone has any questions about these, you can always reach out to me about them. But a number of states are increasingly mandating paid sick leave as well as bereavement leave. That is often unpaid, but nonetheless, there's a little bit more attention being drawn to it. As well as you all know very well in Georgia, parental leave for public employees. That is something that has been trending more and more, as well as safe leave, which is leave for victims of sexual and domestic violence. So I do just want to note those, but we're going to focus on those top two for today. Next slide, please. Thank you. So just quickly, I do want to give a little bit of background on FMLA leave, something that I'm sure all of you are familiar with, but that sometimes the differences between FMLA and paid leave can get a little bit lost. And so I do just want to highlight those. So FMLA leave is leave that is job protected, and it is 12 weeks, but it is unpaid. And that's something that some people don't know, and how it really differs a lot from the state sort of solutions for paid leave that we've, seen proliferate over the last few years. And the reasons that you can access FMLA leave are relatively narrow in comparison to state options. It's typically for parental leave, so to care for a new child, to care for a family member who has developed a serious health condition, or yourself if you develop a serious health condition, and then also for military exigencies. So if you have a family member who is preparing to be on military leave, helping sort of adapt and prepare for that. FMLA only applies to private employers with 50 or more employees, as well as all public agencies. And what that means, if you could advance, Catherine, is that 44% of workers in the country, as of our most sort of recent research that we have on this topic from 2018 from the US Department of Labor, do not have access to even unpaid leave. So if something, comes up where they need to care for themselves or a family member, in a serious medical crisis, there is not access to, protection of their job if they need to take that. So in order to address that, states have taken a number of different approaches, and we will look at the first one here, which is paid family medical leave programs that are publicly funded. All of these that we have, which there are 13 states total, as well as Washington, D.C., cover leave for reasons that mirror FMLA. So again, a serious personal medical issue, or that of a loved one, as well as parental leave. And some states will also cover leave for military deployment related reasons or related to sexual or domestic violence. And one thing to note with state approaches here to PFML programs is that they have expanded significantly what the definition of a loved one includes in comparison to FMLA. So under FMLA, you can access that leave to care for a spouse, a child, or a parent. It does not cover siblings, doesn't cover grandparents, doesn't cover partners or significant others that you were not married to. And so a lot of states have chosen to include broader definitions under their laws. Next slide, please. Cool. So again, 13 states and DC have these programs. We do have resources at NCSL if you are curious about the specifics of these programs, but these are the states that do currently offer them. And with the publicly funded programs, these are the most established approach to providing paid family and medical leave. The first was California, but we've seen a number of states in the last couple of years, adding to the total tally. And the length of the leave that you can access does vary from state to state and also the reason for requesting it, but usually it's around 12 weeks. And then interestingly, in the last couple of years, we've also seen a huge growth in a different approach that is a private approach rather than a public one. And it is essentially voluntary. So when in comparison to the PFML programs that are usually cover pretty much every employer in the state and are funded through payroll tax, this is instead using a private insurer model. It basically alters the state's insurance code to allow insurers to offer paid family and medical leave insurance that employers can opt into offering for their employees as a benefit. Again, this is very new. The first state to do this was in New Hampshire, and that was like at the very end of 2022. So we are still seeing how this is playing out and how many employers choose to take this option. But it is something that we've seen proliferate pretty quickly. The only real difference in approaches with this across states is that New Hampshire and Vermont, who were the two earliest creators of this option, they do mandate one specific insurer to work with the state to give that coverage, whereas others just allow employers to choose any insurer that offers it. And then this is just a quick, map that sort of lays out the different approaches across the country. You can see, potentially relevant to Georgia, across the Southeast, the voluntary paid leave insurance option has been spreading very quickly. So, definitely could be helpful to reach out to other states that have taken this approach and see what they think. As well as, we can see that the PFML model is kind of scattered all across the country with different states adopting that as well. So that was a very broad overview. One thing to note is that every single program does look a little bit different. And so if you have any questions about this, you can always reach out to us and we can give more information about it. And then I also just want to highlight we have these additional resources available at NCSL that you can check out. And then this is our contact information, so feel free to reach out to us at any time.
Thank you, everybody, for such a good presentation. Do you have any questions? Do you have any questions? Senator Watson, do you have any questions? From a general standpoint, I just have one quick
I
one.
do not have any questions. Thank you. Appreciate you asking.
From a general standpoint, is this an area like caregiving services that states are still trying to kind of wrestle with as far as like trying to find their best fit with all the different tax credits and things that are available? Just trying to get an idea, is it still kind of in motion, so to speak, where states are trying to figure out where they really need to kind of address these particular issues?
I'll just say on the tax credit component that we have seen every year we see small changes and some big changes to the income thresholds, changes to the amount of credits, and now I would say with HR1 passing, states are going to have to also say, okay, what are our constituents in our state receiving as a result of the federal? How does this support them? What are the additional supports? How are costs rising, and is this sufficient? How do we adjust our policy? I think one area that states are definitely wrestling with is, how the refundability, non-refundability question, how do you support lower income families in a more targeted way, so that they are able to, access benefits that can support their family. So I think we are definitely continuing to see that push and pull in terms of finding the right balance to be most supportive.
I can add from the thank you, Chair, for the question. I'll add from the health program side. I think what we're seeing in terms of trends is both that COVID-19 highlighted a need for long-term care services and supports. And we have seen increasing pressure on states from a direct care workforce perspective. So who is providing services for these long-term services and supports, particularly in the home and community, which is both cheaper than institutional care, but also where people prefer to be. And increasing pressure on the direct care workforce, I think, has led some states to examine family caregiver approaches. So we've seen several states enact, not dissimilar to this, study committees, workforces, task groups, advisory committees on how to structure family caregiving, and to examine family caregiving policies, both within kind of health focused policies as well as kind of across other policies as well. So yes.
There's no other questions. I want to thank you once again for a great presentation. I really appreciate it, and want to thank you for coming and spending so much time on this particular issue. Thank you.
Thank you very much, Chair Jones. It's a pleasure being here.
Thank you for
Absolutely.
having us.
So our next presenters are going to be from the Minnesota Department of Human Services Community First Services Support Team. We have Eric Huddleston and Janine Wilson. Are you available?
Yes, we
Hi,
are.
everybody.
Great.
Thank you.
Yes. Floor is yours.
Wonderful. Thank you. I'm just going to take 1 second to share my screen and then we can get started. Okay, can you see that okay?
Yes.
Okay, perfect. Hi, everybody. My name is Erin Haldine, and I am the CFSS, or Community First Services and Supports Policy Lead in the Disability Services Division at the Minnesota Department of Human Services. And I am joined by Janine Wilson. I'll let her take a minute to introduce herself.
Hello, I'm Janine Wilson from DHS, and I supervise the Home Care and Self-Directed Services team as part of our Disability Services Division.
Thank you.
Go
Nice
ahead,
meeting you.
Erin.
Yeah,
Good to
thank
meet
you for letting us. Yeah, thank you for letting us join you today. We're here to talk about our newest self-directed program, Community First Services and Supports, which we often refer to as CFSS. So Community First Services and Supports, or CFSS, is a Minnesota healthcare program that allows people to remain in their home and community and provides more choice and control over the services that they receive. So we actually started this program back on October 1st of 2024. We started transitioning individuals over from our personal care program and our community support grant program over to CFSS. So we use a number of authorities to do this: the 1915K, 1915I, 1115, 1915C, and 1915B authorities. We anticipate that we'll be through fully transitioning everybody to the CFSS program by September 30th of 2026. So it is going to take about 2 full years to transition everybody over. So the history of CFSS. CFSS was part of a bipartisan reform enacted by the 2011 legislature. It was a reform to reform the long-term service and support system for seniors and people with disabilities and other complex needs to achieve better health outcomes, increase independence and community integration, reduce reliance on institutional care, and ensure quality, consistency, and long-term sustainability of programs. So the supports made by the Minnesota Medicaid system was really unsustainable at that time unless these changes occurred by 2020. So the goal for this program is really to keep as many people into their own homes as possible. And we obviously want to keep people out of less or more expensive facilities and programs, and really try to kind of avoid a one-size-fits-all benefit package. So this just allows more supports and control for people receiving the services. So what are the advantages of CFSS? So CFSS is a really great program. It allows more eligible workers for people who are receiving services. So their parent, if they are a minor, can be paid to be their worker. A spouse can be paid to be a worker. And individuals who are eligible for CFSS themselves and may be receiving services can also be a worker for another person receiving CFSS. We also make payments for worker training. So that is a covered service. People can use their funds for a personal emergency response system, or what we call PERS. Goods and services are covered as long as it is related to the person's assessed needs and it replaces the need for personal care. And the units or dollars that a person receives, they can be used flexibly throughout the month or flexibly throughout the year based on the person's needs. So we have several groups that help a person facilitate CFSS. So we have our lead agencies, and this is our case managers that are with the counties, our managed care organizations, or our tribal nations. And they are responsible for overseeing and coordinating the delivery of services for the individual. We have a group that is new to Minnesota that is called Consultation Service Providers, and they're responsible for educating the individual people receiving services and helping them write a service delivery plan. And then they help them with kind of ongoing support throughout that plan year. We have our financial management service providers, and they're responsible for people who are using what's called the budget model, which I'll touch on in a few slides. But they are responsible for helping the individuals employ workers, make payments to their workers, and then also make payments for the goods and services that are approved. And then we have our CFSS provider agencies, and those are the agencies that are hiring individual workers to go into a person's home. They facilitate what's called the agency model. And again, I'll go through that in a couple, or actually on our next slide here. So they are hiring and training and supervising all of the workers for people who have chosen the agency model. So like I said, we have the two different service models for people. The first is the agency model, and the second is the budget model. So when anyone is assessed for CFSS, they can choose between the two different options that are available to them. So with the agency model, this is a model where our lead agency, so again, that's our county, tribal nation, or managed care organizations, they authorize units to a person. So those units are in 15-minute increments. And the person will select a CFSS provider agency to employ all of their workers. And so that's really similar to our PCA option that we have today. But it will allow individuals to hire workers to go into their home and work with them. And then we have what's called our budget model. And this is where the authorized units are converted into dollars. And so the person is receiving a budget rather than units that are available for them. And then they can use that budget to pay for workers or to pay for goods and services or PERS or other items that the person may need. And so again, one is really, we think of that as units or hours for a person, where the other is a dollar amount that's available for the person. And so anybody, again, who's assessed for CFSS, they can choose between either model, and they can actually switch between models throughout the year if they need to. So the eligibility criteria didn't change for anybody who is receiving PCA services in the past to receive CFSS today. So the eligibility criteria is that they need to use one of Minnesota's healthcare programs. They cannot live in a hospital, a nursing facility, or an ICF home. They cannot live in housing owned or controlled by the agency that they're receiving services from. They must be able to direct their own care. And then, of course, they have to be assessed for CFSS. And so Minnesota has an assessment that is really like a universal assessment tool. We call that MIN Choices. And it's an assessment that really includes age-based developmental milestones for people. And that will determine if they're eligible for CFSS and the number of units that the person would be eligible for. So that's just a little bit of information to understand what CFSS is. These next few slides are kind of where we're at today. So you can see on the screen here, we have about 56,000 people that need to transition from our current PCA program over to CFSS. And so we have about roughly 12,000 people who are working through a managed care organization that we have kind of limited data on with those individuals of how many people have transitioned over to use CFSS, so transitioned from PCA over to CFSS. And so we're working to gather that information. But as of today, this last box here, the smaller one, we have about 9,000 people of that 56,000 who have fully transitioned over to CFSS. We have about 25,000 people who are in process of making that transition. So they have an authorization to begin services and they're working towards that transition, but have not fully transitioned over. So they're still using the PCA program today. And then we have about 11,000 people that have not made any progress towards the transition yet. And we're working to get all of those individuals into that first step of making that transition. So this is data as of September 30th of this year. So it is pretty current. But of the 56,000, we have roughly 10,000 or so people that have transitioned over.
So Erin, I think just one thing to mention,
Mm-hmm.
you mentioned consultation services, and that's a brand new service for Minnesota. We created it to be a little bit about orientation to the program and help in building the plan and those kinds of things. And that has to happen before you actually get into the personal care part of CFSS. And so the blue square there, working towards transitioning, are people that are in consultation and working with consultation to build a plan that will then be approved, and then they will be fully in CFSS. But we've got a lot of people right now learning about CFSS and building their plans.
Thank you, Janine.
Yep.
So some statistics. We have, well, this slide says about 49,000 people served. You know, my last slide said 56,000. It can change based on how many authorizations we have in our system on a particular day. So we have, let's say roughly 50,000 or so people. So that's our annual people served in 2024. And then we just have this broken down by the average person served. Monthly is about 49,000. We project that it will be about 47,000 by fiscal year 2029. We have in 2024, we spent approximately $1.4 billion. And we project that by 2029, that will be closer to $2.4 billion. The average cost per month per person is $2,986, so almost $3,000 per month. And then we have about 900 provider agencies, so providers in our state of Minnesota that are providing this service. Okay, and it's again about 60,000 or so workers. So when we say PCAs, we mean the workers actually going into the home and working with those individuals. Let's see. Okay, so our capacity. So Janine had mentioned our consultation service providers. So this is a new provider group to the state of Minnesota. We only have 17 of them today. And that's 17 providers who can work with that 56,000 people. And so that's really kind of been a barrier for us, is that we don't, at this point, don't have enough consultation service providers to get everybody transitioned over from our PCA program. to CFSS. We're continuously working on getting more consultation service providers. We're going through a process right now to enroll additional providers that we believe will help get everybody transitioned over within this next year.
So
We have
Erin,
yes.
sorry, I just think the consultation service providers are agencies and they can have a number of workers working with them. But currently we have a number of BIPOC providers that may have a small book of business, have one consultation provider or two. So while we have 17 agencies, we have some very little agencies in that grouping, as well as some larger ones. And so that's why we're looking to add more provider agencies. And we're hoping that there are more workers that can join the workforce in this way too.
Thank you.
Mm-hmm.
So we have 900 or so provider agencies that needed to enroll as CFSS provider agencies. So they also needed to make that transition. So our individual people receiving services need to transition from PCA to CFSS. But we also had to have all of those 900 PCA agencies who were up and running as a PCA provider. They needed to re-enroll as a CFSS provider. And so that is another piece that took several months as the program was up and running to get all of those providers enrolled. And then we've just really had limited capacity here at the Minnesota Department of Human Services. We have had to kind of take on the tasks of a lot of our lead agencies. So again, that's case managers, tribal nations, and our managed care organizations. To complete some of those tasks. So we've been really educating all the different provider groups that we have, enrolling those providers, and then we complete the tasks for all of our non-waiver recipients, so all of our state plan recipients. So some actions that we are taking to help with this transition is we run meetings monthly with all of our sponsors and partners to get their feedback, listen to what is happening at all of the lead agencies, partnering with them to listen to their feedback and hopefully be able to change things if needed on our end, or just to understand best what's going on out in the community. We offer what we call office hours to all of our different provider groups every month. So we meet individually with all of our consultation service providers, all of our lead agencies, all of our CFSS provider agencies, and our financial management service providers. So we provide education, we answer questions, we ask for feedback to make sure that we're providing the best service possible. We also put out a request for proposal for additional consultation service providers. So if you remember a few slides ago, we had said that we currently have 17 consultation service providers enrolled, and we had 130 new providers apply to do this service. So we're working through the process of selecting those providers, and so we can increase the number of providers that are available for that service. In addition, we meet quarterly with what we call our implementation council. So this is a group that consists of managed care organizations, consultation providers, our financial management service providers, our CFSS provider agencies, our tribal nations, our case managers, and people receiving services. So the majority of the people on this implementation council are for people receiving services and their family members. And so we seek feedback from that group quarterly. We also offer virtual information sessions to people who are receiving services. And so we've offered several of those over the past couple months just to get the information out to individuals that are receiving services in the state of Minnesota. And we have a navigation team that is helping to actually call every person or email every person that's eligible for this service to explain the importance of transitioning from their current PCA program over to the CFSS program. So we've certainly had to pivot throughout the past year since this program started on October 1st of 2024 to kind of get the feedback from all of these different groups that I've talked about and make sure that the service is being provided in the best way possible to people. We originally had a timeline to get everybody transitioned over within the first year, so that would have been September 30th of 2025. We didn't meet that goal, and so now what we've done is we've provided an extension for everybody to complete that transition by the end of September of 2026. And really a lesson learned, I think, for us is that we transitioned all of the authorities at one time. And I think, Janine, maybe you want to speak better to this, but I think if we were to do it again, we probably would have rolled out the different authorities throughout, or worked on one authority first and then moved to another authority rather than doing all 5 authorities at one time. Do you have anything you want to add for that?
Yep. So what we did was take all of our people in our 1905A personal care benefit and move them into this program, CFSS. And so that's why we have so many different authorities, because we have PCA, state plan plus PCA on all the waivers and our 1115 and everything like that. And it's been monstrous to try to move almost 60,000 people over. And then, we ended up with like less capacity and consultation than we were anticipating. We ended up with, our CFSS agencies not being coded for CFSS and those kinds of things. And so it's just gigantic and very hard to manage. And it would have made more sense for us to do one population at a time, so that we were able to manage a little bit more of the bottlenecks that we've been seeing. We talked a little bit about, should we have brought up the 1915J and then worked on the K and the I? But when you're taking everybody out of your state plan PCA benefit and moving them, we needed the K for the main authority, but we needed an I because there were people that were financially not eligible under the K, and that some people weren't level of care. And so we constantly had to keep bringing in more groups to cover everybody because we didn't want anybody to lose services. So that is definitely a lesson learned. Do not take an entire population and move them. Just do one piece at a time.
Thank you, Janine.
Yep.
And that is our presentation for you. So we'll open it up for questions if you have any.
You have any questions, Senator Wicks? I mean, yeah. Okay. And Senator Watson, do you have any questions? I did have 2. One was, what is a personal emergency response system? What would that entail?
Yeah, that's a good question. So that would be a device that a person would be able to keep on them. Think of like a necklace or a watch where they would be able to push a button in an emergency, and that would call out to somebody for assistance. So rather than having a worker in their home who would be working for them or working with them, they may have time where they want to use that personal emergency response system. So an example, maybe someone might fall in the shower, so they could press a button on their watch that could call for assistance or help.
And is that something that's provided? How is that provided to them? How is that paid for, I guess, is what I'm asking.
Yeah, so when a person is assessed for services, they have the number of units or hours that are available to them. And then if they want to purchase something like a PERS system, they would be able to convert some of those units. So they would reduce the number of hours that they're using to hire a worker to come into their home to then pay for that PERS device. And so that might be, I'm making up an example, but it might be $500 to get the device and then $100 monthly fee, let's say, to keep the service up and running. But they would then be reducing the number of hours that a worker would be in their home to pay for that device. So they might have a combination of both. They could have workers in their home and have a PERS system.
Oh, thank you so much. And my final question was on the consultant service providers. What were the requirements to be one of those consultant providers? Because it seemed like you might be an agency that's kind of large, but you also talked about you might have just a single one-person shop kind of agencies. I was just curious, what are the requirements to be that?
Yeah, the requirements are pretty extensive. We have Janine, do you know what those are off the top of your head? I mean,
A little bit, yeah. So
Okay.
it's, a bachelor's degree. It might be a nurse, a physician, a PA, somebody like that. with some experience of providing services with elderly or disabled individuals. We sort of looked at what we have in our county partners and our MCOs and our tribal nations for assessors and for case managers. So somebody that has that professional background, that understands what an assessment is and how to build a plan with the person to meet health and safety requirements. So we have a lead worker, in quotes, lead worker, that does that. And there may be people that have less experience that work with that lead worker to do the plans. So it's kind of a high bar. But we really expect them to have a good relationship with the people they're working with and be knowledgeable about how you build a plan of care for a community, a person out in the community.
Yeah, and I'll add to that as an organization, there are certain requirements that they have to have as far as insurance and sound financial measures and things like that. And so it's a pretty lengthy process to become a consultation service provider. But we're thankful we had so many submit proposals in this second round, where I said we had 130 organizations submit proposals to us to become a consultation service provider. So we hope to get more up and running soon.
Okay. All right. Thank you so much. Any other questions? I want to thank you guys so much for coming.
Yeah, thank you.
Your work. Thank you.
Yeah,
Absolutely.
we
Thank you so
appreciate your
much.
time and letting us present. Thank you.
Yes. So next up, we have from the Washington State Department of Social and Health Services, Medicaid Alternative Care and Tailored Supports for Older Adults. We have Amy Fink, Office Chief, State Unit on Aging, Mandy Weeks Green, Legislative and Rulemaking Coordinator, Bree Elise Rector, Assistant Secretary, and Dana Allard Webb, Family Caregiver Support Manager. Please come forward. And there they are. Thank you, guys. How are you doing? And we're ready.
I am on mute. Okay. Thank you. We really appreciate the opportunity to be here. I think Dana's pulling up the
Yeah, hang
PowerPoint.
on here. So I think one second. I think I
Take your
chose the wrong screen to share. Nope. Nope. That's so strange. Oh,
Get it?
got it. Can you, no,
There it is.
It is.
Perfect.
Mhm.
Okay.
it's sharing the large one?
Yes.
Yeah.
Okay.
You're all dialed in. Yes. Yes, again, thank you again for the opportunity to be here today. My name is Amy Fink, and I'm the Office Chief of the State Unit on Aging here at DSHS. And I was going to just give a little space for my colleagues to introduce themselves. So Dana?
I'm Dana Allard Webb. I'm the Family Caregiver Support Program Manager for the state of Washington.
Good morning. My name is Mandy Weeks Green. I'm filling in for the legislative liaison at DSHS.
Okay.
Yes. And B had a conflict today and is unable to make it, so we're pinch hitting for B on her behalf. I do apologize, but I am going to go off camera until the end of the slide deck because I'm getting my internet is unstable signal, and I think that will preserve my internet. So my apologies.
No
Okay.
problem.
Yeah, okay, great. All right, so we'll get started. So today we were going to talk a little bit about our evolution of family caregiver programs here in Washington State. To show you that evolution, we were going to kind of take you through a timeline and maybe start with the demographics to kind of outline that for you. Then we were going to talk about how benefits became standardized under our family caregiver program, and also the use of an evidence-based program. So in Washington State, we are using TCARE, which is an evidence-based assessment. And then we were going to kind of conclude with showing you the metrics we glean to measure the outcomes of these really important programs. So with that, we'll get started with the demographics. Dana, can you move that slide forward? Thank you. Okay, so we're going to start off by showing you some of the demographics. This is nothing new. Almost every state in the nation is facing demographic trends like this that we're experiencing in Washington State. This chart displayed here shows the age demographics, and these are both current demographics and then projections for upcoming years. So if you look across adults right now over the age of 60, currently have reached about 23% of our population, and age 65 is just south of 18% of our population. And if you look even closer at the chart and kind of dial into that blue line there, you can see that that has a really steep incline over the next 30 years. And that represents those folks over the age of 85. And that presents some challenges because we just find, and then that age group, even though we have a lot of folks who are healthy at that age and have embraced healthy living, we also have a high demand for long-term services and support due to higher incidence of chronic health conditions, dementia, and of course, mobility needs. You know, in Washington State over the past 20 years, as well as right now, we understand the need to prepare for an aging Washington, and it's been a driver of our policy changes and also the development of innovative programs and implementation of those programs in our state. And with that, I'm going to turn it over to Dana for the next slide.
So this is the newest AARP information that we received. These are specifically for Washington. So yeah, every state has different demographics, and but our amount of unpaid family caregivers went up from 820,000 the last time AARP did their the data analysis up to 1,330,000. So you can see that that we're rolling right along with individuals aging in Washington. We have oh, I'm sorry, Aim, this is yours.
But that's okay. Did you want to take it?
No, go ahead.
Okay. All right. So here's kind of a timeline, and it can kind of give you an idea of how the family caregiver programs have evolved in Washington State. So in 1989 through 2000, you know, the legislature just started to see like, well, we need to put a high priority on serving unpaid family caregivers. There are a lot of people providing unpaid care, and it's really upholding our long-term services and support system, right? So how could we support family caregivers? And if we have supported family caregivers, could we also keep people in the place of their choice longer that needed long-term services and supports? So at that time, there was like one service offered, and that was really respite care provided for family caregivers. Then in 2000, really looked at expanding that service delivery. Like, would it be helpful? Could we support unpaid caregivers and their journey even better if we provided some diverse, you know, services? And like right after 2000, right in 2001, came the National Family Caregiver Support money through the Older Americans Act. We got the Title III money, and that came with a benefit package. And so it kind of provided yet more structure to expand services. So then in 2007, 2008, the legislature said, I think we could get better data and better understanding of the journey of the family caregiver if we were using an evidence-based caregiver assessment. And that was where TCARE became, you know, part of the backdrop and became the tool that was being used in Washington State to assess the journey of the unpaid family caregiver and help to create insight for that unpaid family caregiver on the work that's involved, that really important work of providing care to another. So with that, TCARE assessment was rolled out in 2009, and that was statewide. And then we also had an influx of funding from our state legislature to support increasing services for unpaid caregivers. So that, coupled with the Title III money, allowed us to kind of expand services a bit and provide a modest benefit, but really helpful to people to understand both the care receiver journey, like that person who's ill or needs that support, but also the journey of that unpaid family caregiver. So, you know, after TCARE was in place for a few years, then there was an analysis of data from that evidence-based program. And we're going to refer to that analysis on a later slide, show you some more detail of that. But, you know, it did prove that there were savings. There was an avoidance and a delay of higher levels of care, whether that be through the Medicaid long-term service and support system or through nursing facility care. And at that time, the legislature thought that that was a good investment to invest more in the journey of the unpaid family caregiver. So then in 2017, we wanted to look and could we take an 1115 waiver and could we use Medicaid dollars differently and could we support the journey of an unpaid caregiver? So that is when we launched our 1115 Medicaid demonstration, and we launched 2 programs with that. It was the Medicaid Alternative Care, and we refer to that as MAC. And then we launched also at the same time tailored supports for older adults. And we began to serve eligible caregivers and clients. And I can remember when we launched this program, it was the first time when we would walk into folks' house and we could say, well, we can help you both. We can provide services to not only the individual who needs the care, that care receiver, but we can also help the unpaid caregiver. So MAC and TSOA, allowed us to expand care options for people aged 55 and older. So this would be the unpaid caregiver, or the care receiver, sorry. So they could stay at home and delay or avoid more intensive services, such as moving to a nursing facility or even going on to more intensive Medicaid long-term services and supports. And, could we take a modest benefit and help delay and divert? And also the program provides assistance to unpaid caregivers age 18 and older who provide care for their loved ones. Okay, Dana, back to you.
Thank you, Amy. So we support family or unpaid family caregivers statewide by using the TCare evidence-based assessment tool we have since 2008, like Amy was saying. So our legislature really wanted to know that the investment that they were making was really making a difference for caregivers and also delivering a return on their investment that they provided. So all of our TCare staff are trained in person-centered communication, and through conversations they have with the family care and the TCare algorithm results from the answers that the caregivers give during that screen and assessment. With all that information, we're able to develop an informed care plan for the family caregiver that's really tailored to their wants and their needs. And we really try to explain the why we are recommending specific services, what we think that will do for them and their stresses. So we were able, oh, I'm sorry. So we were able to prove that. And I have added the actual data analysis that was done in Washington that AIM was speaking of. I have it attached to the last page of this PowerPoint under TCare data analysis. So family caregivers, first part of our process is family caregivers take a preliminary TCare screen, and a burden score will determine their eligibility to complete an assessment. And then the services and supports that are recommended through that evidence-based algorithm are what we call the whole meal deal, full meal deal. So we created these funding steps to really focus on the caregivers in the greatest need. So people start off at step 1. Maybe they want to go to a caregiver conference or have a piece of equipment for their like a grab bar or something. And that is what we call step 1. They can only do that one time. And all they have to do is give us their demographics so we can count people that we've helped. Step 2 is up to $500 annually, and that is with a semi-annual TCare screen. The TCare screen really measures the stresses and just what the caregiver is doing and how they're dealing with what they're doing. And they can do that forever if they want to stay at step 2. $500 annually, which is enough to pay for a PERS unit, which you were asking about from Minnesota, or some other things that that a lot of people need, but $500 is not a lot of money. And the AAAs can use their money for however they want, really. And they will, sometimes they'll go above that cap, especially nowadays, because these haven't been updated for quite a while. But then step 3, that's when they take that whole TCARE assessment process. These are the ones we're focusing on. We have the most information about them. And they get the full meal deal of a list of mainly these supports: respite, training, education, consultation, support groups, and counseling, legal and care planning, future planning, health and wellness. And Macandasoa now, with Medicaid money, it's quite a bit more funding. So they've actually added individual providers. So they don't, in FCSP, people have to use an agency caregiving provider. But in Macandasoa, they can have individual providers and they can hire their family members. They also have things like pest eradication and community CCG. Yes, community choice guides. So the average annual cost per caregiver of the FCSP is about $1,094. And Macandasoa can do the average annual cost per caregiver for about $700. They have.
I'm just going to correct one thing there. So the average annual, it's annual and average monthly cost per caregiver is about
monthly
$700.
cost. Sorry.
Yeah.
Yeah.
No, that's okay.
So these services are provided under a variety of fund sources for FCSP. We have state-funded general fund funding, and then we also have, of course, Older Americans Act and Medicaid. Transformation Project is paid for by Medicare or Medicaid. So when we mirrored our successful FCSP program for Macandasoa, they're very, very similar, but there, of course, had to be a few changes because Medicaid rules are different. And with, so that is how we've, Medicaid or Macandasoa have been able to add more services that people need. We also found through the data analysis that I was talking about that offering services to family caregivers has resulted in a 20% reduction in the entry of care receivers into our traditional long-term services and supports program, which is in-home care or residential personal care services or nursing facility care. And that means that our caregiver program, even when funded through general fund dollars, can pay for itself over about a 3-year period by reducing the growth in who is served in traditional Medicaid. And that cost avoidance was also proven again when we implemented the 1115 Medicaid waiver, our transformation project. We can serve roughly 3 to 4 unpaid family caregivers for the same cost of serving one individual in paid personal care services or in a licensed residential setting. And then we can, it goes up to approximately 8 people we can serve for the same cost as a skilled nursing facility. This is a form of rebalancing where we listened to how individuals wanted to be served and then supported their loved ones and developed a program to designed just to do that. And it's really been a win-win for families as well as for state and federal budgets for Washington. Aim?
Thank you. Okay, so Washington also participated in a study to understand the differences in outcomes. What was the outcomes based when we weren't using an evidence-based assessment, and what were the outcomes like when we were using the evidence-based system or assessment, and that's TCARE in this case. And what we learned is that 84% of the caregivers showed improved outcomes in the 6-month period following the first use of the TCARE assessment approach. There were statistically significant improvements in the number of burdens, as well as decreased depression and a greater level of comfort in their caregiver role. For spousal caregivers, there was also a decrease in their intention to place So intention to place as we were thinking about putting the individual into a nursing facility. And so when that decrease happened, there were decisions made to keep their loved one in their home. And then again, the evaluation just really supported that unpaid family caregivers showed that the quality of life of the caregiver is improved through these interventions. And I can say personally from doing, at least 100 T-care assessments over the course of my career, it just helps unpaid caregivers gain insight about their journey. And the more they understand that they're a caregiver, the more willing they are to accept help. And we always hear after the caregiver journey, if I only would have known sooner that I was a caregiver, I would have asked for help. And that's a big deal. Okay, can you go to the next slide, Dana? One of the other valuable learnings from this study was through the screening and the assessment and the consultation. So those steps that Dana was talking about earlier, whether you start out with the screen, then you move to the assessment. And then the specialist who sits down, who's done that assessment, does a consultation and talks over the services and those recommendations that are made from that. We're hearing from caregivers that was the first time people asked them, how are you doing? Because often the focus is so much on the care receiver, but how are you doing? How are you feeling? And then really starting to hear the importance of self-care. So that combined with that insight can be very, very powerful. We know that caregivers are often torn between caring for their own needs and caring for the needs of their loved ones. So 4 out of 5 caregivers reported that the program and the approach really helped them to understand the importance of taking care of themselves, which is crucial in the caregiving journey. Because if you've ever been a caregiver, it's exhausting work. And Dana, I'll turn it back to you.
Thanks, Sam. So everyone knows that it is really hard to find family caregivers. Most unpaid family caregivers don't really understand that they're a caregiver. They think of themselves as their familial role. When I was a case manager and doing T-care assessments, I'd hear people say things like, well, I promised in my wedding vows that I would take care of him, and that's what I'm going to do. Or a daughter will say, I feel like I'm the parent now. But I'm just her daughter, and I'm just helping with, personal care and bathing and things like that. So we really wanted people to be able to self-identify as caregivers and also to give caregiving a value and the respect it deserves. So we created a marketing budget with some of our preliminary MAC and DSOA money funding, and that really showed that advertising family caregiver programs does help to spread the word. One of our marketing efforts adapted this, what you see on this screen, an outreach campaign from the Wilder Foundation based in Minnesota to help us really define what it is to be a caregiver. And due to those marketing efforts from the state and our area agencies on aging, many of the area agencies on aging did see an increase for MAC and DSOA use and for FCSP. So it was a win. And our mission about technology solutions for family caregivers, technology is there and it's going to grow. We really want to guide our tech choices to be helpful and safe and private for our family caregivers. So with the current stagnant funding that we have, and in Washington, we have a scarcity of direct care workers, those paid caregivers who work for agencies and our individual providers. And we also have a growing number of family caregivers who are getting old, who are also getting older and taking care of older people. So technological services like TruAlta will be needed to support unpaid family caregivers. We have made TruAlta free for all unpaid family caregivers in our state, and it's a great resource. There are hundreds of skill building trainings for caregivers. There's chat rooms and support groups, And it educates people about the importance of self-care for family caregivers, which is really important. People really need to learn that their health, their mental and physical health is very important. So the next one, Get Set Up. We have that in Washington, free for people as well. And what Get Set Up can do is for people who are new to technology, if they get a new computer or a new smartphone or a new tablet and they don't know how to use it, a person can actually call a phone number on Get Set Up and they will help them from the very beginning of charging your phone or your computer and turning it on. And then they can, after they get the hang of using a device, they can get set up, has a lot of really great ways to be social in that platform. There's all kinds of classes, there's yoga and Tai Chi and how to use your iPhone camera, all kinds of things. So then the last thing I have here about technology is, we use TCare as an online, it's a computer platform, I guess. And we recently partnered with TCare Inc. to update some of their terms and the wording that they use and phrases to make TCare process more culturally sensitive. And we had people who work with family caregivers, unpaid family caregivers from all different neighborhoods and cultures and communities come to help us redefine. Some people spoke languages that either they work with people who speak languages that the word depression does not even mean anything. There's no word in their language for depression. So we helped TCare, let's talk about that, about depression just in the symptoms that people are having. Could you sleep? Did you have trouble sleeping in the last week? Were you sad or were you more sad than usual? Things like that to help people understand. And so we're working now to change that in our system. All of those, or we actually did change that. And we're working now on changing our documents that are in 9 different languages. Go ahead, Dean.
Okay, so we were just going to provide a quick example before we wrap up. This is a couple who received services under our Medicaid Alternative Care, so the MAC program. So, initially they met with their family caregivers specialist, and, Janet is actually the care receiver in this case, and Tom is the caregiver, and Janet actually has a diagnosis of dementia. And Tom is the caregiver, and as a result, he's doing all the household tasks and shopping, cleaning, preparing all of the meals. He's also helping Janet to take all of her prescriptions. And he's not complaining about any of that work, but it's wearing on him. That kind of Janet follows him around all day long in the house, and repetitive questions, and that sometimes she's kind of mean and aggressive verbally, and just really kind of struggling with that because he enjoys caregiving for her. So under the MAC program, there was some services that were set up. So there was household and errands that came in and helped Tom, so gave him relief that he didn't even realize that he was stressed from. So felt that relief come off of him. And Janet then took part in a memory care and wellness program where she left the house and went and joined in activities with others that were sensitive to the dementia that she's experiencing, so that it was a safe space for her to be social. And she would come home in a better mood, and that was a system that kind of worked out for the couple. So both received services and both benefited from the services, and it did help to make things go better. And over time, Tom learned more about dementia and kind of had a handle when Janet was following him, and the verbal aggression, and how those actions were actually communications from Janet, kind of how to manage that. So that kind of gives you an idea of one of the examples. I think the next slide is just some resources for you all if you're interested in those. I don't know if you wanted to go through those quick, Dana.
I don't think so. I will send this because this is a little bit different from the version we sent you, but we can send this out to you. Mandy can send it. So you have those resources available.
Okay. And I was going to come back on camera and see if my internet will hold out and see if there's any questions. We would welcome that.
Hey, thank you so much for the presentation. Any questions, Senator?
Thank you.
All right. You have one question coming. There you go.
Yep. Thank you so much for your presentation and being with us today. I just have one question for you. How do you address caregiver shortages and ensure adequate access across rural and urban areas?
Amy,
Yeah.
you want to take that?
I'll start it and then you could kind of chime in. We have a rule with our family caregiver support program that we had to work with home care agencies. And we've just recently introduced what we have in Washington State, or what we call individual providers, where folks can bring on a family member or a friend or something like that. And that has really given a boost to our Macintosoa program as well, as far as filling those respite. So before we enacted the individual providers, we actually had a pretty lengthy wait list for respite services. And they were, filling that in with other services then, but being able to fill that, we're seeing a really big shift. So that's been a really positive change. We have not enacted that in our family caregiver program, but we are seeing a good bit of success with it for Macintosoa, and that has helped alleviate that. Not the total answer. We still have a shortage of workers, but it's made some significant strides. I don't know if you wanted to add anything to that, Dana.
In our administration, we do have a training unit, and they have been they're very they're getting very good at coming up with ideas to help attract direct care workers to that career. We have, at the last AARP report that came out, Washington was had the highest wage for direct care workers in the United States. I don't know if that's still true. I haven't been able to go through that entire report yet. But we still are struggling with hiring direct care workers. And so it's obviously more than just wages. I think moving towards being able to have different opportunities, you can climb the career ladder, start off as a direct care worker, work up to a CNA or an LPN or then an RN. That has been, they're trying to make that a reality. They also are working with a lot of our high schools to provide the training that people need to become a direct care worker in high schools. And then once they turn 18, those students can, they get out of high school, or even while they're in high school as a part-time job, they could be a direct care worker. So they're really working hard to help with that, but it is a problem everywhere, even in Europe and all over. It's really tough.
Thank you so much.
And that unit also, I would add to that unit also started a navigator program. So they'll actually, handhold somebody through the application process, because it can just be intimidating. Some of them are just fearful of going through the steps to get employed. So if that's what will help, they will provide them help every step of the way. So just trying to think outside of the box on what would be the barriers to providing that kind of employment.
I had a quick question on the example that you gave with the you talked about the meal prep and the shopping. Was that like once a week, once a month? How many times do you kind of get that respite care there, or to help with the caregiver?
Yeah, that's a great question. Normally it's done in once a week, approximately 5, sometimes up to 7 hours a week. Some people choose to split that and do 2.5 hours twice a week. That's a little harder to fill because it's hard for home care agencies or the individual providers to drive to the client's house and have such a short stay. So, oftentimes those are easier to fill if we do them once a week. So, but sometimes it's possible to do it twice.
And one other one, what metrics were used like to determine when you say the caregiver improved, like a stress burden, objective burden? Was that through a questionnaire? Was it in-person kind of interviews, or how do you make that determination that you got those improvements?
Go ahead,
You want
Dana.
me to take that one, Eve?
Yeah.
We used the data that we collected, that TCare collected, and also our state. They analyzed the data that we got from the questions that people answered at their initial screen, and then 6 months later and a year later, how their stress burdens had changed.
Absolutely. Thank you. Any other questions? I want to thank you guys so much. Great information. I really appreciate it. Thank you.
Thank
Thank
you for
you.
having us. It was an honor.
It's an honor. Yeah.
Absolutely. Absolutely. Thanks once again. So
Bye-bye.
our next group is how structured family caregiving looks from the perspective of providers working in other states. And we have Dr. Carla Pennington, who's here, I believe. Southern Division Director of Sales and Community Partnership from CareForth. Mike Adams, Director of Business Development and Government Relations. And also Andrew Liu, Director of Operation from Freedom Care. All right. Things ought to be told. Good afternoon. Mic check. How's that? Yes. One more. There you go. Try to check it now.
All right, mic check.
Yeah, I guess it'll work.
All right.
We live with it.
All right.
It's
Hey,
on.
good afternoon, Mr. Leader, members of the study committee. We really appreciate this opportunity to be here with you all today. We do know that time has passed, and we want to be good stewards of time. So we will be as effective and efficient as we can. First off, my name is Mike Adams. I'm the Director of Government Relations, and I'm joined here by Dr. Carla Pennington, who is our Director of Community Partnerships. Together, we're honored to share how CareForce work through the Structured Family Caregiving Service is helping Georgia families keep loved ones safely at home while supporting the caregivers who make that possible. We will also touch on the differences and similarities of how the SFC service is administered in other states. Today's discussion builds on what you've heard from DCH, Department of Community Health, as well as Prime Care, which is another SFC provider a few weeks ago. Again, focusing on practical solutions that strengthen home and community-based service care and sustains the family caregiver workforce, which underpins it. Okay, so at the heart of CareForce's mission is a simple idea that family caregivers are an essential part of Georgia's long-term care infrastructure. They are not an informal add-on. They are the backbone of care at home. Our role is to help states and health plans recognize and unlock that value. improving outcomes for members and caregivers while lowering costs for Medicaid and families alike. For more than 25 years at CareForth, we've refined the structured family caregiving, or SFC model, including partnering with DCH back in 2019 to bring this service to Georgia. Today, SFC is available statewide, giving caregivers, especially those in rural communities, the support, coaching, and confidence they need to care for individuals with complex health and behavioral needs. Across 10 states, we now support over 10,000 Medicaid members and 15,000 family caregivers. And we're proud that our clinical model of care for administering SFC has been NCQA accredited for over a decade. I will now pass the presentation over to Carla.
Hello, Mr. Leader. My name is Dr. Carla Pennington. I'm the Southeast Division Director. I also reside here in Atlanta, Georgia, in District 40. So as you can see on the screen, we wanted to discuss about the family overview, a family example of what their life was before structured family caregiving, after they received support from SFC, and then some of the results and outcomes that you'll see on the screen. So behind every data point is a family story. Miss H and her mother, Miss G, are one example. When Mrs. G's dementia and chronic illnesses progressed, her daughter left her job to provide care at home. Through SFC, she received both financial relief and one-on-one coaching, guidance on managing dementia behaviors, nutrition, and stress. Together with the waiver case manager, our coach made sure the right equipment and supports were in place, including a portable oxygen tank so her mother could safely leave the home. The result, Ms. G lived safely and comfortably at home for 2 more years with no ER visits and only 1 brief hospitalization. It's families like this who remind us that we can achieve through SFC model when policy and practice works hand in hand. Next, we're going to highlight Georgia's families supported by CareForth in the SFC model. So today, CareForth supports families in Georgia statewide. We are actively supporting 117 of Georgia's 159 counties, reaching both rural and urban communities through partnerships with waiver case management entities under the Elderly and Disabled Waiver Program, also known as EDWP. The members who are supported by family caregivers through CareForth often live with multiple chronic conditions, mobility limitations, and co-occurring behavioral health needs. Nearly 1 in 4 live with Alzheimer's or another form of dementia, which is more than twice the state's average. The typical caregiver is a woman in her 50s, most often a daughter caring for her aging parent. Our average member is 69 years old, and the majority of those who are receiving care at home from family are Black women, reflecting both the diversity and the strength of caregiving families in Georgia. Next, we will have the key benefits of structured family caregiving for the payers, members, and caregivers. The outcomes of this model speaks for themselves. The 10,000 plus Medicaid members who are participating in SFC with CareForth in the 10 states in which we operate experienced 28% fewer injurious falls and 21% fewer ER visits compared to similar populations. They remain at home on average more than 3 years, generating more than $60,000 per person per year in savings for the state. But beyond the numbers, the satisfactions among the 15,000 plus caregivers is striking. 98% say CareForth helped them meet their goals, and 95% feel less burdened because of the support they receive from CareForth. With that in combination, stronger outcomes, lower costs, and higher satisfaction is exactly what Georgia is striving for in its home and community-based services.
All right, thanks, Carla. Okay, on this next slide, you'll see a tabular kind of comparison of Georgia, and also we took a sample of 3 other states as well. So when we look across other states that provide SFC, including North Carolina, Louisiana, and Ohio, we see service requirements that balance maintaining integrity in the service while extending flexibility that allows more family caregivers to access the support made available through the state's waivers. Objectively, there are some of Georgia's current rules that limit certain caregivers and members. For example, requiring members to meet both nursing facility home level of care and 5 hours of daily personal care is more stringent than most states. Again, where they offer an opportunity to re-examine how access, actually it offers an opportunity for all of us to re-examine how access can be expanded while maintaining program integrity. In regards to caregivers, Georgia's rules limit who work outside the home or also care for minor children. In other states, you'll notice that those caregivers may participate as long as they can meet the members' needs safely with oversight through care plans and monitoring. This flexibility has not reduced quality or compliance. Rather, it has expanded access to committed family caregivers who might otherwise be excluded. Now, all states, including Georgia, require background checks, but several use tiered exclusion systems that recognize the passage of time and rehabilitation, again, balancing safety with fairness. So again, this is just a sample of some of the lessons worth considering as efforts continue to find more opportunities for accessibility for Georgia's family caregivers. And so as I advance to our second to the last slide, I think the important part here, Mr. Leader and committee, is as Georgia looks ahead, we see several opportunities for collaboration with DCH and this committee. First, aligning SFC with DCH's broader HCBS goals to retain and support the family caregiver workforce. Secondly, it's achieving greater consistency and quality across providers so that every caregiver receives the same high standard of coaching and oversight. Third, preserving SFC as an efficient, cost-effective alternative to the hourly home care and nursing facility care. And finally, ensuring stability and program requirements so providers and families can plan confidently. So here with CareForth, we are eager to partner on initiatives addressing dementia, social determinant risk, and rural provider capacity. All are essential to keeping Georgia safely cared for at home. So as we close, I want to leave the committee with one key thought. Georgia has an opportunity to build on what's already working. Structured family caregiving is helping families stay together. It's easing pressure on the state's healthcare system and strengthening communities. With a few targeted policy updates, particularly around strengthening the provider network and increasing caregiver eligibility and access, we can help even more families benefit from the service. Before wrapping up, I also want to acknowledge our colleagues at Freedom Care, who I believe will be presenting immediately after us. We've definitely valued standing alongside them, as well as Prime Care, other providers who are sharing the same mission. So on behalf of CareForth, we want to thank you again, Mr. Leader, and the committee for your time and your dedication to Georgia's caregivers and the loved ones that they support. At this time, we'll entertain any questions.
Yeah, I did just have one. Like we just looked at the previous state that talked about they did kind of like advertising so people kind of know what services are out there. How do people find you? Is there a connection point with the state is like telling them these are kind of like the providers that are out there, these are folks you can go to kind of get services and things of that nature?
Yes, so they're working with their waiver case management agency. So they're able to allow them to know all the services that they may qualify for.
And it also is everyone's uniform as far as qualifications are concerned. Would that be correct? Okay.
Yes, sir.
All right. Any questions? Okay, that's all I have right now.
All right, thank you.
Thanks for your time.
So next up, we have Andrew Liu from the Director of Freedom Care, Operations Freedom Care. Thank you, Mr. Liu.
All right. Good afternoon, Chair Jones and Senate committee members. Thank you for the opportunity to speak with you all today. I'm Andrew Liu, Vice President of National Expansion at Freedom Care, and I'm here to share how Structured Family Caregiver, or SFC, is helping states like Georgia deliver better care for families, which means the better outcomes, lower costs, and stronger communities. As well as our colleagues and Mike and Dr. Pennington have at CareForth have alluded to and referenced a lot. We've noticed those better outcomes in rendering these programs in multiple states as well. So let me share my screen. All right, since our colleagues at CareForth went through structured family caregiving, a little insight, well, come from it a little different overview where SFC is a Medicaid-funded home care and home and community-based service that compensates and trains family members to care for loved ones who would otherwise need that institutional care. It's built on these pillars that I'm listing here on the screen. It's financial support, clinical coaching, and emotional well-being. For the member, it means staying safely at home in the comfort of their home. For the state, it means better health outcomes and lower cost per enrollee. And for the caregiver, it means that recognition, training, and relief from burnout. There are several win themes that we want to think about with SFC compared to other programs. It's empowering the family members, reducing the workforce shortages that we've noticed, the scalability and the sustainability. It is a cap cost per day, as opposed to an agency model program where that plan of care can fluctuate week to week, month to month. In a structured family caregiver, it's a much more predictable growth model. And with the aging population in many states, especially in rural areas, it's a much more sustainable model long term and a predictable budgetary model as well for the state. Let's talk economics. Across the country, states save on average of $61,000 per year per person when someone receives care through SFC instead of a nursing home. And as our colleagues at CareForth mentioned, it's typically a 3-year stay on the structured family care program. And that's equates to about $190,000 in cumulative savings per participant. These aren't abstract numbers. They translate into direct cost savings for the Medicaid relief and a stronger HCBS infrastructure. As I mentioned, for the aging population, we'll use Georgia as an example, where the 60 plus and 65 plus data showcases growth significantly in rural counties, especially where older adults are trending higher. Some of these counties are Quitman, Towns, Union, where 40% of those residents are already age 60 plus. It's a problem that's facing us today, and it's a problem that's going to increase as the years go on. Georgia has about 40,000 nursing home residents. That's 3/4 are already on Medicaid. If we shifted just 10% into the structured family caregiving program, Georgia alone would save $200 to $260 million a year. On the home care side, moving 10% off of traditional tenant care members, SFC will yield about $48 to $96 million in annual savings. That's a per member delta. That's a straightforward off of the $24K a year of savings. And that's where I wanted to showcase where that data is coming from. This slide makes it clear on how those numbers are summed up annually, where nursing home care averages about $7,000 a month. Home health aid care, the attendant care model that I allude to, is about $4,000 a month, and in SFC averages about $2,000 a month. So that's for every 1,000 Georgians in SFC. Instead of institutional care, that's roughly $60 million a year in state savings. Now, comparing to Georgia Medicaid and other long-term care options, I want to pause and take a look at how that long-term care is structured in comparison to other states. The CCSP, or the Community Care Services Program, and the Source Waiver are underneath the EDWP, and that's the HCBS. These programs have proven to serve Georgians well already, but they have been increasingly constrained. There's wait lists along, there's provider capacity, then the direct care shortages in the rural areas that we mentioned. Families are already filling in to cover those gaps, often without pay, training, or relief. That's where SFC bridges that gap. It's home-based, and as you see here with the oversight, it's family delivered, but professionally supported. And it sits neatly inside the existing waiver structures. Agencies handle the oversight, the training, and the reporting so that the state can gain the capacity without adding administrative burden. This is how Georgia can evolve from program management to family empowerment. Health outcomes. These are where SFC shines even more. We've noticed about 45% fewer falls and 21% fewer ER visits. One of the programs that we've done is analyzing UTIs as a common ER visit, especially women who are a predominant population that are aging in the home. That was a good example given by Dr. Pennington earlier. UTIs are very common in women with menopause. And in a proper innovative solution at Freedom Care, we track and leverage the caregiver in the home using the mobile app to log urine odor, urine frequency. These types of things are designed by our chief medical officer to assess when there's differences in behaviors and patterns every day, and then prevent that hospitalization or ER visit. That's leveraging that emotional bond of family caregivers and tracking that higher compliance with medications and care plans to prevent that ER visit. Let's talk about the caregiver, right? This is about dignity and sustainability. We want members to age with dignity and grace, family members to be recognized and rewarded. SFC offers that tax-free stipend, respite breaks, and coaching to reduce the burnout. Massachusetts is a really good example where in their policy, there's a medical leave of absence provided annually and a non-medical leave of absence that's instituted. When these caregivers are supported, the entire system becomes more stable. Structured family caregiver recognizes that family member as the backbone of the system. This is why SFC fits Georgia so well as other states. Alluding back to the aging population and the increasing members in the rural areas and percentages as well. There's caregiver shortages. Those families are already in those homes, and agencies like us at Freedom Care are able to support them compliantly with the innovation around data and the implementation, helping states to care for more people at home with the same dollars. The social return is just as important. Families can stay together, care recipients stay active in their communities, and caregivers remain financially stable. That reduces their reliance on other state programs, and that is why that's what a healthy Medicaid system looks like, one that invests in the families and then strengthens the communities. Opportunities to expand structured family care in Georgia and other states. Georgia has already the foundation for success. A few policy adjustments would unlock the full potential of structured family care, allowing approved SFC providers to expand service areas beyond county lines. That immediately gives families more choice and reduces the bottlenecks in coverage. Secondly, implement service level agreements across stakeholder agencies to speed up case processing. Every delay risks pushing a person towards institutional care. Third, allow spouses to serve as caregivers. Other states have proven that with the right guardrails, this delivers better outcomes and keeps care consistent in the home. And finally, simplify the caregiver enrollment process so families can start care quickly instead of waiting weeks for approvals. These are small changes with big results. Expand the access, improve the equity, and keeping Georgia families together while protecting the Medicaid budget. In closing, structured family caregiving helps states achieve three things every policymaker wants: better outcomes, lower costs, and stronger families. It leverages what already exists, your waivers, your agencies, your families, and turns them into a sustainable system for long-term care. With a few targeted policy updates, Georgia and other states can lead their respective regions in home-based innovation and set a national standard for family-powered care. Thank you for the opportunity today, and I'm happy to take any questions.
Okay, I did have one quick one, and that was about the falls, the link between the SFC and the falls. Kind of like, how do we make that determination that the falls go down because of SFC? Just kind of curious.
Yeah, so we also compare our data among the agency model across the states and use the assessments. We use the CMS guided model of STEADY to analyze the fall risk for their behaviors. Then we track reported critical incidents through our mobile app, and the numbers on of members on the SFC program are less than the other programs.
And I guess one of the questions would be, why do you think that is? Just why do you think that would happen that way?
There is a flexibility in the structured family care program to build in your own assessments. Traditional agency models have duty codes that you do, and there's not as much there to innovate upon that. Whereas in SFC programs throughout the states, they have an ability to create your own assessment. They have a minimal requirements, but then we added on top of that. And some policies, I'll use Massachusetts example, they require a biannual fall risk assessment. So sometimes the policy helps support it, and other times you can innovate on top where it's not as regulated.
All right, thank you. Any questions, Senator? No other questions. Thank you so much for your presentation. I appreciate it.
Thank you very much.
Absolutely. And I want to thank everybody for the presentation on that. And we do appreciate you coming and great presentation. Thank you. So we do have caregiving through paid family and medical leave, a group coming up. Ferioza Freeland from the Southern Regional Director of Better Balance. Tracy Marshall, Division Director of FAMLI. And David Gallivan, Branch Manager for Policy and Appeals, Colorado Family and Medical Leave Insurance. Kately Alton, Associate State Director, Colorado Chapter of 9 to 5, National Association of Working Women. Aaron Shakat, Chief Executive Officer of the Paid Leave Authority of Connecticut, and Rebecca Grady, Research Manager, Leave and Care Division of the Washington Employment Security Department. I think they're all on Zoom, and welcome.
Thank you so much, Chairman. Are you able to see my slides here?
Yes, absolutely.
Okay, wonderful. Well, thank you so much, Mr. Chairman and committee, for allowing me to speak today. My name is Ferioza Freeland, and I'm the Policy Director of the Southern Office at A Better Balance. We are a nonprofit organization whose mission is to ensure that all workers can care for themselves and their loved ones without sacrificing their financial security. And I am based in our regional Southern office in Nashville, Tennessee, and have the pleasure of working with organizations across the South, including in Georgia. So first, I wanted to ground our discussion in why paid family and medical leave is needed. At some point throughout our lives, all of us will need time off work to attend to life's most important and challenging moments, whether that is caring for an aging parent or a spouse who's going through cancer treatment, whether that's recovering from our own serious illness or welcoming a child into the family. And that is where paid family and medical leave comes in. This is a policy that protects a worker's income, health insurance, and their job when they need extended time off to address these caregiving or medical needs. And the United States remains one of the only countries in the world without any national paid leave policy. We also know that most Georgians do not have access to paid leave. Over 70% of workers in Georgia do not have access to paid family leave through their employers. And for lower paid workers, access is even less. In addition, we know that the Federal Family and Medical Leave Act, or FMLA, is not an adequate solution for families. As we heard from an earlier presenter, over 40% of workers are not eligible for unpaid leave under the FMLA. And even those who are eligible often simply cannot afford to take multiple weeks of leave from work without pay. So in the absence of federal action on this issue, states are really leading the way. As was shared earlier, there are 13 states and DC that have these comprehensive paid family and medical leave programs in place. These cover nearly all workers in these states. We also know that several states have introduced similar legislation and are seriously considering this policy. And Virginia recently became the first Southern state to pass a comprehensive paid family and medical leave law through their legislature, although it was ultimately vetoed by their governor. But this indicates a growing momentum and interest in this policy area, including throughout the Southern region. So next, I wanted to give a general overview of how these state paid leave programs work. Each state is different and the details vary state by state, and we will be hearing shortly from some individuals with more details on how their state programs function. But in general, these are state administered programs that are funded by small payroll contributions. Those are typically split between employers and employees. And the idea is similar to a program like Social Security, for example, where everyone pays in a little bit into this fund, and then everyone can benefit from that and draw from it when they have those family or medical needs. This is essentially, once the program is up and running and the contributions are coming in, these are essentially self-funding programs, and that includes the administrative costs to the state. Those are covered typically by these payroll contributions that are coming into the program. And one major benefit of this program structure is that, number one, it reduces costs for businesses because costs are essentially being shared. And it also alleviates the administrative burden because the state is administering that program and handling claims and paying out benefits and processing all of that. So this structure is especially helpful for small businesses who often may struggle to afford paid leave on their own, or they may not have the infrastructure compared to them providing this on their own, or even some of the voluntary private insurance options that we heard about earlier. These types of program structures tend to be beneficial for smaller businesses. And in some states, the smallest businesses are actually allowed to participate in the program and provide paid leave to their employees at no cost without paying the employer portion of the payroll contribution. Moving on to some of the key elements of these policies. First is the covered reasons for leave. We typically see parental leave included, and that usually includes birth, adoption, or foster placement of a child, caring for a family member with a serious health condition, recovering from your own serious medical condition, needs related to the military deployment of a loved one. And then, as we heard earlier, more states are starting to include what is called safe leave, which is essentially for victims of domestic violence to secure safe housing, attend court appointments, or any other needs to ensure the safety of themselves and their families. The next piece is the maximum number of weeks. Typically, this would be 12 weeks within a year period. And some states also provide additional time for certain serious circumstances. The next piece of this is the wage replacement rate. That essentially refers to what percentage of a worker's regular pay are they receiving while they are out on paid leave. And so typically, you're not going to get 100% of your regular pay, but what many states have done is to ensure that lower paid workers receive a higher percentage of their wages while on paid leave. And that is to ensure that they're able to actually afford to take this leave and benefit from it, and that the wage replacement rate is not so low that they're unable to take that paid leave. And there's also typically a cap in place for the maximum weekly benefit that a worker can receive while on paid leave. Again, these are all in place to ensure that the program remains solvent. The last piece here is it's really important that the employee's job and health insurance are protected. And so they're able to return to their job or a similar position after being on leave, and that they will not be punished or fired for taking paid leave. Lastly, I wanted to share some points on how paid family and medical leave strengthens businesses and the economy. And because we have several states who have implemented these programs, we do have some great data from those states to show that paid leave improves employee recruitment, retention, productivity, and morale. And this point is really important. Paid leave keeps people with caregiving responsibilities or medical needs attached to the workforce. So according to a survey by the Bipartisan Policy Center, over 70% of adults who are not in the labor force cite personal health or family caregiving as the main reasons they are not working. And among those adults who are caring for family members, paid leave would make them more likely to have either stayed in their last job or to return to the workforce. And this really makes sense, even from an employer standpoint. If you have an employee whose parent is diagnosed with cancer and they're going to need several rounds of treatment and surgeries, it would make more sense for that employer to allow the employee to take those few weeks of paid leave and then return back to work rather than risk losing that employee altogether if the employee feels that they have no choice but to leave their job in the absence of having access to paid leave. And then the employer has to pay high costs in order to rehire and train someone to replace that employee. We know that turnover is very costly for businesses. And so this is one tool to help keep those individuals in the workforce. And finally, paid leave maintains economic security for families and supports at-home caregiving, which we've heard a lot about today. Just making sure that families can cover their expenses and medical bills, and to be able to make that choice to care for their loved one at home. And this also can help reduce the burden on our formalized caregiving system. So this is a really critical piece as well. And in conclusion, Georgia has a really exciting opportunity to take the next step towards paid leave for all. Of course, Georgia has already made great progress by enacting paid parental leave for public sector employees. And as a next step, the state could consider bringing in an independent firm to conduct a cost study of different options for a statewide paid family and medical leave program. This would provide some numbers and data based on Georgia's unique state economy and workforce, and really just provide more information as to inform your policy decisions moving forward. So that concludes my presentation, and I'm happy to take questions or turn it over to our next speaker.
We'll just probably go to the next speaker, but please stay on because I did have one question for you, but I'll go to the next speaker and keep going. Thank you.
Thank you.
So next we have Tracy Marshall.
Hello and good afternoon, committee. My name is Tracy Marshall. I serve as the Division Director for Colorado's Paid Family and Medical Leave Program. We're getting our slide deck pulled up for you right now. And joining me today, I have David Gallivan, who serves as our branch manager for legal and policy. So basically, he can answer all the really difficult questions. And with that, I will pass you over to David to get us started today.
Hello, and thank you for the opportunity to address you today. Talking about paid family medical leave is one of my favorite things to do. So let's take a look at some of the history of how we got to where we are in Colorado. This chart starts with 2019, but the history actually goes back a few years before that with multiple legislative attempts to enact some sort of a program. None of those were successful, and so in 2019, a task force was created, resulting in a final report and recommendations for such a program. That did not result in new legislation. What happened in Colorado, and we are unique among states in this, is that we went to the ballot. And so the voters of Colorado passed Proposition 118 with 57% support. So we're the only state that has enacted a paid family medical leave program via the ballot. That program kicked off in 2021. We started collecting premiums in January of 2023, and we began paying out benefits almost 2 years ago, on January 1st, 2024. It's somewhat amazing to me that it has already been 2 years. It feels a little bit like 6 weeks and a little bit like 10 years. So I guess you average that out, you get to the right place. We've just passed then our 18-month milestone at the end of Q2 of this year with over 175,000 claims and over $1 billion in benefits paid. And so that is money that is going back into the state of Colorado, into workers' pockets to help them navigate some of these sometimes joyful, sometimes scary, sometimes difficult situations in their life. So eligibility, who are we looking at here for family? It is intentionally broad in Colorado. It applies to any individual who meets the definition of employee under Colorado law, who works in Colorado, and who has been paying premiums. It includes essentially every Colorado worker, public, private, nonprofit, religious, domestic workers, seasonal temporary employees, part-time staff, work visa holders. Really the only people who are excluded are federal employees and railroad workers. And you can blame Grover Cleveland for that last one. Self-employed Coloradans can also participate by opting into coverage and paying their own premiums. So they can come join our program voluntarily and get a safety net that a lot of times as a self-employed individual, you don't have. You're the one who does the work for your business. And if you can't work because of health or needing to care for somebody else, the work just doesn't get done. And that means there's no income coming in. So we're really proud of that opportunity for those self-employed individuals. We do offer a couple different types of leave. Our 5 core types are parental bonding, medical leave, care leave, military exigency leave, and safe leave. And those have been described earlier in today's meeting. Starting January 2026, we are going to become the first state to offer neonatal care leave. This is additional leave for parents whose newborns require intensive care. We're pretty proud of this program. It's going to be, as I said, first in the nation, leading the way on this. But when you look at the numbers of allowing parents to be in the ICU with their newborns, the numbers of positive outcomes increase pretty dramatically. So allowing those parents to be off work and to have some financial support, it's going to save lives. And it's exciting to see that this is happening in Colorado. We're really excited to be implementing this program. So then let's talk a little bit about benefits. As Ms. Feroza said, Ms. Freeland, this keeps people attached to the workforce, and that's huge. Without PFML, a lot of times when people experience one of these life events, they leave the workforce and they never come back. They slip into poverty very quickly. They can't pay rent. They can't make their car payment. They don't have a place to live. They don't have a way to get to work. That makes it a lot harder to get a new job. It's so much easier to keep people out of poverty than it is to pull them out of poverty. And this is one of those things that helps, keeping people job attached. So we offer up to 12 weeks of leave each year. It goes up to 4 weeks for a birthing parent with a pregnancy complication, and starting in January, potentially another 12 weeks for that neonatal ICU leave. Workers receive a portion of their wages. This is on a sliding scale. So for low income earners, it's up to 90%, and that percentage drops as people earn more money. And very importantly, it's job protected. Employees have a right to return to the same position after their leave ends. Together, these protections make family one of the most comprehensive paid leave programs in the country, ensuring workers don't have to choose between keeping their job and caring for their family. We are the family division. We're very pro-family, and making sure that people have that opportunity to go meet those care needs for their family members. One last thing that I will talk about before I hand it back over to my boss, Tracy Marshall, leave intervals. So we emphasize flexibility. Health conditions, family responsibilities, those don't always match up with our calendar. So we support 3 types of leave. Continuous leave, which is the most straightforward. This is a block of time, typically something that can be somewhat predictable for how long somebody's going to need, and they're just going to be completely off work. Reduced schedule, which is where somebody continues to work, but perhaps works less days. The key thing about reduced schedule leave is it is consistent and predictable. So we know that somebody, for example, they might be working half-time, so they'd be working 4 hours a day instead of 8, or they might need 2 days a week off, and so we can have that schedule. The third kind of leave is intermittent leave, and this is for something that's not really predictable, where we know there's going to be a need for leave. So for example, somebody who suffers from migraines and doesn't know when they're going to have a migraine, they can be approved for intermittent leave that will be available to them when they need it. Or if we have somebody who has a relative they're caring for who's undergoing chemotherapy, who might need to take a day off or 2 days off on that individual's schedule, and it may not be as predictable. So again, we want flexibility. We want to make sure that people have access to the leave in a way that works for them. And with that, I will turn it back over to Tracy.
Thank you so much, David. Let's take a look at some of Colorado's claim data. So what I can tell you is that since our benefits began paying out, Coloradans have filed more than 255,000 claims, which we think is a powerful indicator of how deeply this program is already embedded into the lives of working families. Nearly half of all the claims that we're seeing, so around 47%, are for medical leave. That means that workers are using family to recover from their own serious health condition to enable them to be able to return to the workplace healthy. About 1/3 of the leaves are for parental or bonding leave. So that's for those new parents to care for and to connect with their new child during those first critical weeks. Care leave accounts for 13%. Those are Coloradans that are stepping in to care for their parents, spouses, or loved ones. And that's that sandwich generation that we hear about so often. The remaining 17% of leaves cover other types, including the safe leave that was referenced earlier for those impacted by intimate partner violence and sexual assault, and then those who are taking time away from work to support a loved one who is being deployed with the military. What we're seeing is about 60% of claims are filed by females in the workforce and about 40% being filed by men in the workforce. So let's dial in a little bit closer on that care leaves with our sandwich generation workers. When it comes to caregiving, family care leave is most often used by working adults in their 40s and 50s. This is what we all know as the sandwich generation, those workers who are balancing employment, childcare, and elder care responsibilities. As you can see in the image on your screen, there's Coloradans across the entire state. We're in suburban, rural, and even remote mountain regions, and every region is utilizing family to care for their family members. Care leave is also something accessed by Coloradans across a range of socioeconomic profiles. The table you can see is a list of the top 10 zip codes for care leave in Colorado by claim count. While most of these zip codes span metro areas, the median household income of this set ranges from $52,000 a year to nearly $150,000 per year. So we're reaching everybody within the workforce. We also have some data that will show you how care leave is being used to care for family members experiencing chronic or degenerative conditions that primarily affect our older adult population, such as Alzheimer's, dementia, joint replacements, COPD, stroke, and cancer. Taken together, all the data we have on caregiving gives a very clear story. Paid leave programs equally improve the lives of those who need care as well as those who are giving it. And this care data on your screen, we put this together for AARP. They wanted to know what was the most common reason for workers over the age of 50 to be taking caregiver leave. And what we found is to care for typically a parent who is undergoing a knee replacement, who has had a stroke, or who has challenges from dementia. What we found for those adults who are under the age of 50 that are taking time away from work to care for a loved one, they typically seem to be taking time away from work to look after a child who either is suffering with autism or who has recently had their tonsils removed. As far as economic data and our impact and reach is concerned, what we know right now is that we've paid out benefits to over 187,000 individuals for a total benefit amount of $1 billion. And that was in our first 18 months of having the program up and running. In Colorado, the maximum amount of money you're able to receive per week is around $1,300. What we're seeing right now is typically the average person taking leave from family is collecting around $907. We do understand that we've made a significant financial impact, and we're also now starting to see the systemic impact for Colorado as well. Over the past month, the Prenatal to 3 Policy Impact Center has ranked Colorado #1 in the nation for resources available to families with young children, and family was specifically cited as one of the key reasons why. In their research and analysis, paid leave is a key factor in increasing labor force participation, reducing postnatal infant mortality, improving parents' mental health, and fostering better child-mother relationships and child health. As you can see, other downstream impacts as listed by the Policy Centre include that family has helped to lower childhood food insecurity. We've enabled more children to receive appropriate developmental screenings. We're seeing fewer mothers reporting poor mental health, and we're seeing fewer children living in poverty. We're also partnering with researchers to expand on and in some cases explore other impacts and outcomes. An ongoing study being conducted by Dr. Kim at Denver University shows a promising link between paid leave and reduced income-related stress among parents. She wrote to us in August to report that from the data she's seen so far, she can hypothesize that family has already mitigated the effects of income-related stress during the perinatal period, resulting in healthier parents and children once they leave neonatal care. Another study being conducted by Dr. McNellan at UC Health, that's the University of Colorado Healthcare, is drawing positive associations between paid leave and the reduction of domestic violence. Dr. McNellan also wrote to us in August to report that the implementation of family is improving and even saving lives by protecting some of the most vulnerable from the devastating effects of violence in the home. Finally, a quote we have here is evidence given to us by one of our own Colorado residents themselves. This is from Kelly, who used family leave earlier this year. In her testimonial, which we've linked here for you to watch later, she tells us that family saved her life. With that, I will pause and we'll be happy to take questions after all of your presentations have wrapped today.
All right, thank you. So next we have Miss Caitlin Altone. What's next?
Hello. One moment, I will share my screen. Great. Well, thank you so much for having me share with your committee today. My name is Caitlin Altone. I'm the Associate State Director for the Colorado chapter of 9 to 5. 9 to 5 in Colorado, we have been leading in paid family and medical leave, before we successfully passed it, and continue to engage through our implementation. Which I'm so glad you've been also able to hear from our state administrators of our program. And today I'd love to share a little bit more about our work in Colorado and how we have arrived at paid family and medical leave. As was shared, we did pass our family program through a ballot measure. We worked to pass paid family and medical leave for years before this, and as was said, had unsuccessful legislative attempts. But I do want to highlight our success through the ballot because the major lesson of this is that when the people have the opportunity to decide, they support and want paid family and medical leave. This was shown that we had a margin of 15 percentage points in its passage, and we had voters who supported it, across our entire state. So our exciting moment was November of 2020, and in 2024 is when our program became live with benefits available. To tell you a little bit more about our journey for family, I'd love to highlight these pillars of an effective, equitable, paid family and medical leave policy as you consider, the solutions in your own state. The first one is when creating paid family and medical leave policy, we understood we needed to be very intentional with how we crafted each of these. First being the qualifying events, which is, the reasons why a person can take paid family and medical leave. So both as a caregiver, the person being able to take that, also the person who needs to be taken care of if they are the worker themselves, as well as the other reasons that have been described for you. It's important that the length of leave, the amount of time available is adequate, it is sufficient. In prior to the passage, we heard many stories of people with adverse outcomes because the amount of time they had was insufficient, or did not have it at all. Additionally, that how that amount of time can be taken is adaptable and flexible. For example, there are people who need caregiving or time off for themselves for continuous reasons. Maybe that's weeks of recovery following a surgery. Maybe you're a caregiver taking care of someone, on dialysis who has to have appointments that they make or unpredictable situations that impact the type of caregiving they need to provide. Additionally, wage replacement. For many working people, this is such a significant lever of an equitable policy because without sufficient wage replacement, when you are a minimum or low wage worker, it's unrealistic that people will be able to access policies like this. And lastly, job protection. People are meeting the demands in the moment, but also of their families in the long term. And they need that security of knowing that their job will still be there for them when they're able to return. As you heard, in Colorado, this is how we have created ours. I'll share briefly to not be repetitive, but our program allows up to 90% of wage replacement, with the lowest paid workers receiving that highest percentage. And then 12 weeks for reasons of, parental leave, personal serious health condition, caring for a family member, safe time, as well as military deployment. We have extended leave in scenarios of pregnancy or birth complications. And we recently added extended leave for parents of NICU infants, which will become available soon. Something I'd also really like to highlight for you for your purposes is the definition of family. When we were working to pass family in Colorado, this was extremely important to us to have as part of our policy and make sure that we had this to really meet the needs of caregivers. An expansive family definition allows everyone who needs to be a caregiver to be one. We know in most families, it doesn't fit one look, one type, one arrangement of relationships. So while our policy names explicitly many types of family relationships, it also includes anyone who is akin to a family relationship. And so that allows those caregivers to step up and have that support that they need to take care of their loved ones. Additionally, I'd like to highlight that our family program is a state-run program. In working towards our own solutions in Colorado, this was the best fit, the best solution for us because of these reasons. Our program is self-funded, and it's done through payroll premiums that are contributed by both employers and workers. The share is split 50-50. There is exemption for employer share for workplaces with less than 10. And our program is doing very well. that, our premium amount is able to be adjusted and can be lowered as our program remains solvent and based on the needs of the program. As you heard from our family division folks who are administering it. And statewide and state-run program was so important for us because it's the way of implementing paid family and medical leave in a way that keeps costs low and very accessible for everyone because we're all pooling together as a state. Workers benefit because of the flexibility this creates in terms of access. They're able to integrate paid leave across their jobs and types of employment. And, we had small business orgs and all of that as part of our coalition. And that really benefits those small workplaces to make them, competitive, comparable, and level the playing field of this benefit. To share a little bit more about our pathway to having family in Colorado. This, of course, started well before our actual passage. We had our family coalition, which was a very broad coalition of support. It included, member-based organizations like 9 to 5, also unions, direct service organizations. It include organizations of small businesses. And by the time we got to 2020, we had about 90 organizations as part of it. In 2019, our next step was there was a bill that created an implementation task force, which conducted an actuarial and created recommendations, which we have linked here if you would like to review those. And then, of course, our ballot measure implementation and when benefits became available. Finally, I would like to share with you a bit about why paid family and medical leave, what's the right solution for us and for impacting the needs of our workforce in Colorado and their families. At the time before we passed, broadly, the majority of workers did not have access to paid family and medical leave. And the people who have bared the highest burden of this unmet need have been women, especially women of color and our lower wage workforce. And while family is able to address needs across a lifetime, really, whether it's from becoming a parent, taking care of your own health, caregiving for loved ones, these are life events that people experience, typically everyone at some point. And so paid family and medical leave is a really effective tool to address these disparities that do exist across gender, across race, across economic situations. And I'm glad you were able to, hear from our family division in Colorado, the success of our program and how this has been an effective tool for us.
Thank you so much.
Thank you.
Thank you. And the next person is Erin Choquette, Chief Executive Officer, Paid Leave Authority of Connecticut. You're on.
Great, thank you so much.
Absolutely.
Let's get this started here. So I am Erin Choquette, the CEO of the Connecticut Paid Leave Authority. We are a quasi-public state agency, which is somewhat unique to Connecticut. We are state employees, but by setting us up as a quasi-public, it gave us a little bit more flexibility with regard to some of our staffing and regulatory requirements, which was necessary because we had less than 2 years to get started. The law was passed in 2021, and we began taking the payroll deductions in the law was passed in 2019. We began taking payroll deductions in January of 2021, and paying benefits in January of 2022. Connecticut's program is entirely employee funded. The employees pay 0.5% of their wages up to the Social Security contribution limit through a payroll deduction. So the employer's responsibility is to process that payroll deduction and remit the money to the authority, but the money comes from the workers. The contributions are pooled into the Paid Leave Trust Fund, which is administered by our state treasurer, but it is not considered to be state money. It cannot be used for any state purposes other than running the program and paying the benefits. When the 2019 law was passed, it also amended the Connecticut FMLA. So our two laws work together. If a worker needs time away from work for a qualifying reason, they apply to their employer for job-protected leave under Connecticut and/or federal FMLA. But in order to receive money while they're not at work, they can apply to the Paid Leave Authority for income replacement benefits. Like Colorado, our benefits are graduated, determined by the worker's income. Lower income workers receive 95% of their average wages with a sliding scale, and it's capped at 60 times the Connecticut minimum wage, which in 2025 was about $942 a week. One of the most important factors that our legislature always asks me about is our fund solvency. The fund continues to meet the 3 solvency metrics that we developed with the assistance of independent actuaries. We look at our ability to pay our bills in the short term and the long term, which is particularly important because we are capped at the 0.5%, which is the lowest amongst all of the state paid leave programs. As of the close of fiscal year 2025, we had a fund balance of over $585 million. The contributions that we brought in during that same year were over $477 million. As you can see from the slide, we get a good amount of our contributions in the first quarter of every year. There's 2 reasons for that. First, lots of employers, if they pay bonuses at all, those bonuses are paid in the first quarter. So that brings up the average. And second, with that Social Security contribution cap, as employees earn more money over the course of the year, they hit that cap and then the contributions stop. So you do see that impact in the second, third, and fourth quarters where we just don't receive the contributions any longer. But we are pleased that the contribution amount is going up every year. That is attributed to sort of the state of Connecticut's economy and the fact that our minimum wage increase has increased each year since 2020. In the early years, it was a couple times per year, and that does have a rising impact. Our program applies to most workers in Connecticut. Our statute says that if you are an employer with 1 or more employees working in Connecticut, you are covered unless you meet one of the explicit exemptions, which includes the federal government and the railroad, as David mentioned. Our non-union state employees are covered. Unionized state employees can collectively bargain in. Municipal employees are excluded unless their union-wise workforce bargain in. Some school employees are covered. They're covered if they don't require teacher certification. If they do require certification, they're excluded unless they bargain in. In each of the last 2 years, our legislature has acted to expand the number of employers who are covered. We also allow sole proprietors and self-employed individuals who reside in Connecticut to opt into the program. So again, as of the close of the fiscal year, we had over 147,000 registered employers, over 3,400 sole proprietors, and basically we look at about 1.5 million workers who are protected by our program. I just want to take a moment to talk about our private plan. We call it our alternative compliance. So all covered employers are required to ensure that their employees have access to the paid leave benefits, but employers are allowed to apply to the authority for permission to comply with the statute through what we call a private plan. This can either be an insurance policy or it can be a self-insured program. Either way, the plan documents must conform to the standards that we set at the authority with the assistance of the Department of Insurance, which also regulates the insured policies. Because Connecticut's program is entirely employee funded, An employer cannot offer a private plan without the buy-in of its employees. So the majority of the employees at that employer must vote in favor of the proposed private plan. The employer must provide proof of that when they apply to us for this permission. If the plan is approved, they are approved for 3 years, and we do audit a portion of the private plans every year. We have 4 different types of audits that we conduct to make sure that the application process met our requirements, to make sure that they are not taking more in contributions than the 0.5% that the public plan allows for, to make sure that their claims processes meet our standards, and for self-funded plans, to make sure that they meet our solvency. We have about 835 employers that have approved private plans. The majority of those, almost 93%, are fully insured programs. Because we've had private plans now for over 4 years, we have had a number of private plans that started this process with a private plan and came into the public program, although we also see folks who've gone the other way. I do think it's important to allow this opportunity, particularly for multi-state employers, but it is really critical that we have this review and audit authority to make sure that the employees who work for these employers receive equivalent benefits to their friends and neighbors who work for the employees who are in the public program. Eligibility for benefits in Connecticut is based on your connection to workforce, and we look at earnings for that as opposed to hours. The eligibility standards were specifically designed to allow for flexibility. So part-time workers, per diem workers, seasonal workers, as well as the workers who might change employment across the year are all able to be covered. Our eligibility has 2 prongs. The earnings piece, you have to earn at least $2,325 from one or more covered employer in the base period, in the highest earning quarter of the base period, which is defined as the first 4 of the 5 most recently completed quarters. This is the same base period that our Department of Labor uses for unemployment insurance. That is deliberate because we have an agreement to be able to access their data, which minimizes the burden on the employers and allows us to validate these earnings. In Connecticut, given our minimum wage, a minimum wage worker can meet the $23.25 in a quarter by working an average of 11 hours per week. So this is very accessible. You also have to show that when you apply for benefits, you are either currently employed by a covered employer, you were employed by a covered employer at some point in the 12 weeks before your claim start date, so we can capture those seasonal workers and recently unemployed workers, or again, you're an enrolled sole proprietor or self-employed individual who resides in Connecticut. Like Colorado and many other states, we do allow benefits for block leave, reduced schedule, and intermittent leave. Block leave is definitely the most common type of leave that people need when they're applying for benefits, but caregivers use intermittent leave at a higher percentage than folks who take other types of leave, which makes sense because they might be taking their loved one to the doctor, they might need to meet with the doctor, they might be balancing care with other family members, or perhaps they are on call if a paid caregiver has to call out. Our benefit duration is up to 12 weeks in a 12-month period for most leave reasons, although we do allow 2 extra weeks during pregnancy. We also have safe leave. Connecticut safe leave law is capped at 12 days in a calendar year, and we provide benefits for those 12 days. As I mentioned, we started paying claims in January of 2022. Since that time, we have paid, and actually just got my October data while I was on this call, so it's actually over 182,000 Connecticut workers have received benefits, and we're actually closer to $1.4 billion paid in benefits since inception. If you look at the average approved claim duration for all types of leave, it's almost 8 weeks. If you look simply at caregiver leave, it's closer to 6 weeks. In the few years that we've been paying benefits, we do see applications increase year over year. Just from 25 to compared to 24, it was almost a 10% increase. And as fiscal year 26 has begun, we're continuing to see even a 10% increase over last year's numbers. I think this shows that this is a program which is truly needed and valued by Connecticut workers. The average weekly benefit payment is about $759 a week, or you could look at it as about $100 a day. Again, that's looking at all types of leave reasons, but caregiver is about the same as when you pull that out from the other leave reasons. Like Colorado and the other paid leave states, the number one reason for people to take leave is their own serious health condition. For us, that's about 54%, followed by pregnancy and childbirth, then bonding, then care of family member, which is over 13% last year, up from 12% the year before and 9% when we started. Our demographics in terms of people who are taking leave across the entire program versus caregiver are relatively similar. We do see that women are taking leave at about 62% versus men at 35%. I think this is a cultural phenomenon. We see it in other states as well. For us, the number one age gap for people taking leave are folks between the ages of 29 and 44. For caregiver leave, you see the similar number, but one thing that I think is interesting is that with caregiver leave, folks who are between the ages of 45 and 60 and take almost as much caregiver leave as folks between the ages of 29 and 44. So if you look at just caregiver leave, they're at 38.37 versus 38.25%. I think this is a reflection of folks who are in the sandwich generation and are caring for their parents as well as their children and their spouses. Which leads me to my next slide. We do have a broad definition of family in Connecticut that covers parent, spouse, child of any age, sibling, grandparent, grandchild, as well as folks who are related by affinity. Those are your chosen family. Other really reflects that we allow some in-law relationships. The number one reason that people take caregiver leave is to care for their own parent, followed by caring for their spouse and caring for their children. I will say that the related by affinity language was something that was very hotly debated in Connecticut over the years, with a lot of concern that it was going to be this exception that took over the whole program. That has not been our experience. Folks who need leave for someone who is not related to them by blood or marriage often tend to be their longtime significant other, they're who's simply not married to them, as well as people who perhaps their great aunt who is equivalent to a grandmother or an incredibly close family member. It's a very small percentage of our program, but for the folks who need it, it's life-giving. Again, most folks take leave on a continuous basis, but intermittent folks for caregiver is actually closer to 20% rather than the 10% you see overall. Before I close, I just want to share with you a little bit of the changing response we've seen with employers in Connecticut. The Connecticut legislature took up the topic of paid leave for many years before it actually passed in 2019. And in the coalition of supporters, there was a robust employer presence, particularly among small employers. So we always had some employers who recognized the value of paid leave, but there were also many employers who were very afraid. Our Chamber of Commerce and our Business and Industry Association expressed a great deal of worry and concern. They had a whole parade of terrible things that they thought might happen, and those things haven't happened. The program is solvent. People are not, one of the big concerns is that workers would just go hog wild, right? That as soon as the law passed, they would take all this time off. Everyone would take 12 weeks every year at the max. And that's just not what's happening. People use only the time they need. And as you saw, if you're averaging about 6 to 7 weeks, that's much less than the 12 to 14 weeks that's available under the law. And when they take that time, the workers report feeling more connected to their employer, more willing to go back, and they are more productive. Employers are telling us that they see those benefits as well because employers in Connecticut do not pay into the program, they're particularly happy that their employees get access to income replacement benefits at zero cost to them. Some employers actually redeployed money that they might have spent on a short-term disability insurance policy to do other benefits like lowering medical deductibles. Other employers said that they couldn't afford to offer short-term disability, so that they feel like they can compete and retain their workers because they're not losing their staff to larger employers who can offer these better benefits. Also, employers report to us that they really value predictability and uniformity, and they appreciate the structure that Connecticut FMLA and Connecticut Paid Leave provide to them. They know what they have to do, they know when they have to do it, and we provide resources to make sure they do it correctly. I will say, babies get born, people get sick, whether you have paid leave or not. Paid leave exists to make those life events things that workers can manage and stay in the workforce, as Caitlin mentioned, and so that employers can plan for it and know that they're showing the value to their workforce, which is their greatest asset, and still being productive and effective. So, we're still new. We're older than Colorado, but we're still relatively young for a state program. But all things are looking great as far as we're concerned here in Connecticut. I will encourage you to check out our website at ctpaidleave.org for more information about our program, including more detailed about how the employers pay, the employee contributions, how the program works. I also have all of our annual reports linked to the materials we provided, so you can see how our program has grown in the past few years. And thank you again for allowing me to share our story with you. If you do have any questions, I'm happy to answer them, and I've given you my contact information if you'd like to reach out in the future.
Thank you so much. We have one other speaker, then we will be opening up for questions because I do have a few for each speaker. And that is with Rebecca Grady, Research Manager, Leave and Care Division, Washington Employment Security Department.
Thanks for inviting me to share today. Can you see my presentation all right?
Yes.
Awesome. So I'm Rebecca Grady, Research and Data Manager for Leave and Care Programs at Washington Employment Security Department. You've got a sense of some of the approaches to policy parameters and implementation from the other presenters here today. And I'm going to focus in on program outcomes and impacts that have been emerging since Washington Paid Family and Medical Leave launched benefits in 2020. Although there's some additional slides in the packet we sent that includes some background information on policy parameters. So here you can see in the graph the breakdown of types of leave applications we received in our last fiscal year. Early on, we had more claims to bond with a new child, but over the years, that's been slowly shifting towards leave for one's own or a family member's serious medical condition as the program matures. As Erin mentioned with Connecticut's experience, we have also continued to grow year over year. And so we're still in that kind of, even 5-6 years in, still in that kind of new program growth phase. Evaluation analyses also show that by the 3rd year, most new parents in Washington were taking leave through our program, and nearly half of new child leaves were made by fathers, which was encouraging to see. In addition, there's been strong overall program use by Black men and women, which is particularly promising given studies on leave tend to find that Black workers are less likely to take leave when needed. Paid leave also supports economic security. So analyses from the Urban Institute, this was a collaboration with the US Department of Labor, estimate that if our program had been up and running in 2018, the poverty rate among families receiving benefits would have decreased by nearly 9%. And the poverty gap, which is the amount of resources needed to bring families experiencing poverty up to that supplemental poverty measure line, decreased by 26%. This in turn would have reduced participation in means-tested programs, which would have resulted in a savings to the tune of $47 million. So that's kind of the macro financial impact view. We've also done some surveys and interview projects to learn what leave customers think about leave and the impact it's had on their lives. So this graph illustrates some perspectives on the financial aspects of leave in particular. A high majority of customers indicated reduced financial stress, and 70% said they'd have had a financial crisis without these benefits. Most folks also felt that the amount of time and benefit level were sufficient, although not everyone, of course. It's probably helpful to share, for context, that Washington allows up to 12 weeks of either family or medical leave in a year, or up to 16 weeks combined family and medical leave, with an additional 2 weeks available to pregnant or birthing people experiencing complications like a C-section. The benefit amount, like Connecticut and Colorado, is progressive based on a formula, with lower wage workers receiving a higher percentage of wage replacement, up to 90% of their typical weekly wages. In another project, we asked folks, this was specifically about a survey of caregivers using leave to care for their own or a family member's serious medical condition. And we asked them what they would have done without the program. Starting on the right-hand side, most folks indicated they would have struggled financially and also not gotten the care that either they or their family member needed. We haven't yet been able to dive into broader causal impact evaluations. Launching in 2020, COVID is a confounder in all of our analyses, but we can posit that delaying care and missing appointments would be likely to result in worse health outcomes. There's lots of other research out there that demonstrates that link. About a third of folks also shared that they wouldn't have taken any time off, and about a fifth indicated they would not have stayed in their job. Hearing directly from customers in interview, I've included here a few things folks have shared. I won't read them to you all word for word, but these include paid leave as a life-saving program. That bottom quote was from a parent whose son was experiencing a severe mental health crisis. Others talk about birth recovery and successful breastfeeding experience, which echoes other research on leave that shows paid leave is associated with healthier babies, better maternal health, higher rates of breastfeeding, all those positive health impacts. We've also found that paid leave is good for business. A key aspect of this, as other folks have shared, is that when employees can take leave while experiencing a medical or care need, they can stay employed, and employers thus retain talent. In Washington, we've seen about 95% of those employed a quarter after taking leave being with the same employer they were with before they took leave. The Washington program passed with bipartisan support, and likely a contributing factor there was that businesses recognized the benefits to them of having a statewide program. We did a statewide survey of employers in 2018, so this was just a year after the program passed, but before it was implemented. And 3/4 were in favor of the program at that point, with support cutting across all kinds of businesses and industries. The top positive impacts noted by employers were around employee morale, productivity, turnover, and that ability to provide competitive benefits. As you've heard from other presenters, we also heard from small employers in particular that they were happy for a state program to exist because they wanted to provide their employees with leave, but couldn't afford to offer benefits on their own. That picture at the beginning of my presentation was a real small business that was one of several that were so excited they participated in an early marketing campaign. Still, having an employee on leave is harder for small businesses. Recognizing that disproportional impact, the Washington program also included a couple features to help. On the premium side of things, premiums are, in general, split between employees and employers based on a formula and the proportion of family versus medical leave that is taken. But small businesses are exempt from contributing the employer portion of the premium. They still withhold the employee portion and remit that to employment security. Their employees still have full access to the program, but those employers just don't pay that employer portion of the premium. In addition, small and medium-sized employers can access grants when they have an employee on leave. And these grants can partially offset payroll-related costs related to an employee's leave, things like hiring a temporary worker and continuing to pay the employee's health insurance premium. A further benefit available to all businesses is that if they have a permanent employee take leave and they hire a temporary worker and then lay that temporary worker off when the permanent employee comes back, the paid leave program and the account will cover the costs of those unemployment insurance benefits so that it does not end up affecting the employer's experience rating, thus raising their unemployment insurance premiums. So finally today, I'm going to turn to a couple lessons we've learned around policy design that might be useful for your consideration as you're thinking about policies. When we look at who is using leave relative to the Washington worker population, one of the things we see is lower usage among workers with lower income. So the lesson to highlight here, I think, is to think through how eligibility requirements might shape access to leave. So this graph shows approximately quintiles of Washington workers by wages. For context, for those of you looking at that lowest category and thinking it seems $19 seems pretty high, the Washington minimum wage is $16.66 an hour. And then we compare it to the percentage of workers in those same wage brackets that have eligible work history, and then also those that use leave. So in Washington, in order to be able to take leave, folks have to have worked 820 hours in a qualifying year period, which is approximately the year before leave begins. And what this graph shows is that the underutilization of our program by low-income workers is largely attributable to that eligibility requirement. It explains over 80% of the gap there. Another lesson that we thought would be useful to share is in around who people are caring for when they're using family care leave. In particular, a couple of years ago, we expanded the definition of family to include any close relationship within which there's an expectation of care. Like Erin shared in Connecticut, we heard some fear around this change that it would explode leave usage, but we've seen relatively modest use. Only about 1% to 2% of family care leaves approved are approved using this expanded family member definition. On the leave application, we also ask folks who they're caring for, and in the table there, we've grouped what they write in. By far, the most common situation is unmarried cohabiting partners taking leave to care for each other, and secondarily, extended family like aunts and uncles caring for nieces and nephews. I'll leave it at that, but thanks so much for inviting me to share today and look forward to any questions you have.
Thank you so much. And I kind of like go, but thank you for the presentation. I'll go up to the top right quick. Ms. Freeland, do you have information for us about how many states are using the 12 weeks on the family leave?
Yes, thank you for the question. I can get you the exact number. I think that is the most common maximum amount of leave across all of the states. But as some presenters have mentioned today, some of the states allow for additional leave beyond that 12-week amount for certain purposes, such as, for example, Colorado recently added additional time for families who have a child in the NICU. And so it varies by state, but I can certainly get that exact number for you.
Thank you so much. And this would be for each one. We can just start, I guess, with the Colorado folks and then Connecticut. They have to apply for the benefits for each job, or how does that work within your particular state? So we'll start with Colorado and then Connecticut and then Washington.
Certainly, I'm happy to take that one for Colorado. If you have multiple jobs, let's say you're a bartender by the evening and work at Target during the day, you would just need to submit one claim to us. And if you need to take leave from both of those employers, we would link those claims for you.
Thank you.
In Connecticut, we would look at all the jobs that you have in Connecticut and use the combined total to determine your eligibility and your benefits. So that claim would be one single claim. However, in Connecticut, the job protection is handled through the employer. So the employee would have to talk to each employer and explain their leave circumstances, which actually I think is a feature, not a bug, because some folks can take leave from one job, but maybe not from the other. And frankly, if they want their job to be held, they need to let their employer know where they're going. They can't just ghost them. So that's how it's handled in Connecticut.
Thank you so much.
In Washington, there is one claim, but it includes all of the work history from any employer that the person had in the qualifying year period that factors into the benefit amount. And then it's up to employees and employers to work out the exact schedule of who they're taking leave from and to be in contact about that.
Thank you. And I had one for and each one can go through this again, but I was going to ask Colorado first because whoever's kind of representing them would be on the education process to actually get the ballot measure passed, because I think he said it got 57% and develop a broad coalition, but kind of like how did you kind of do that education process so the public wouldn't think that the economy would fall completely apart by passing this? Just kind of curious about that.
Yeah, I'm happy to take that. So we did have multiple years of trying to pass it through the state legislature. And through that, our general public awareness definitely grew of paid leave as a possibility for Colorado. We had many partners, including, fiscal experts, policy experts, who were able to show the data in relation to Colorado. And we also used the network of national partners who had wonderful data and examples of how a program like this can function really well in a broad sense, for the entire state economy. So a wealth of resources to draw upon.
Thank you. And I'll also a similar question for Connecticut and Washington, but so because the local businesses, of course, but of course, I guess you would have some multinational corporations, et cetera. How did you kind of develop those kind of partnerships to get this passed? Because I mean, I'm sure you had some headwind against it. So just kind of go through that for me, please. We can do Connecticut and then Washington.
Sure. There definitely are employer organizations that are scared of paid leave and make their feelings known, and that they came out and testified. The Connecticut legislative process took several years. It took a study, it took an actuarial study, and I think in Connecticut, it really was about just trying to address those fears and point out the states like California, New Jersey, Rhode Island that had pre-existing programs for quite a long time. And then we had the benefit of Washington going before us, so we could follow closely along. So their law passed, even though they didn't go implement before our law passed. I think a lot of the multi-state and multinationals were less concerned because they've dealt with it before. And so they just kind of wanted to know what the rules were. They're more interested in standardization, I think, than anything else. But Rebecca, was that your experience in Washington?
Yeah, and I think part of the Washington story is I think like Colorado shared that it was multiple attempts. The Washington actually first passed a paid family medical leave policy in 2007, a decade before we actually got past the real thing. But in 2007, it was passed without a funding mechanism. So then in that time between 2007 and 2017, when a bill passed with a funding mechanism, there were a few things. There was a Department of Labor grant that allowed for states to do some things like get some actuarial analyses and simulation modeling. Ours also included some like message testing and figuring out what policy parameters would be more or less acceptable for the folks. I think also part of the Washington story is that though we did not pass paid family medical leave through a ballot initiative, we are a state that has ballot initiatives. And there was one around paid family medical leave that was polling very well. And so I think that encouraged all parties to come to the table. And there was a negotiating committee made up of business representatives and labor representatives. And actually then when the policy was passed, those folks who had initially negotiated the law became the first folks who were appointed to an advisory committee that continues to advise us as we move forward. So half business representatives, half labor representatives.
Thank you so much. I had just two more, I promise. That's with Aaron with Connecticut. Persons who have the possibility of going into the private plan or the public plan, are you seeing people maybe choosing one or the other, is just kind of split based on their needs, what they may have?
Yeah, so our private plan, it's too many P's. The proportion of employers who have private plans in Connecticut is really pretty low, with less than 1,000. Other states have a higher one. I think part of that is because we require the private plan employers to offer the full gamut. If they want to do it, they have to do the medical side and the family side. Some other states let them pick and choose. And we have that employee vote. So the employers who've chosen, some are insurance companies and are like, hey, this is our business. We may as well do it ourselves. Some are multi-state and they feel like it's just easier. And then some of the smaller employers, some of them told us we are already really generous to our employees and we know we can actually offer a better benefit. So we just want to keep doing what we're doing. So it is kind of runs the gamut.
And I had the last one for Caitlin, I believe. Definition of family you had chosen on there. I wasn't aware. What does that mean when you say chosen? As far as definition of family.
Yeah, for chosen family members. Is that
Yes.
the question?
Yeah, right, exactly.
Yeah. That's language that, we casually use. And that at least many people in our communities may use to just talk about their family members where they don't have that legal or biological family relationship. In canvassing and talking to many community members throughout the years, there was, a meaningful number of experiences of people who, for whatever reason, may have lost some of those pre-existing family relationships that they were born into, whether through whatever conditions. And so they have built around them chosen family members. One of our members at the time was, sharing their own story of being in the hospital, having just given birth, their baby in the NICU, and it was their decades-long friend and roommate who was by their side taking care of them. So they didn't have that type of when we list off family members relationship, but they chose each other and functioned in that really same way that is common for many of us, whether that's our, spouse, mother, brother, etc.
Oh, thank you so much. Does any other senators have anything? Senator Wicks or Senator Watson? I believe that concludes all our questions. I want to thank you guys so much for coming and presenting. Thank you so much.
Thank you so much.
Thank you. Bye-bye.
Thank you.
Thank you. And that will conclude today's meeting. The next meeting is going to be December the 11th? December the 11th. The next meeting will be on December the 11th. And I believe that will actually be the final meeting. And also we will be trying to do recommendations. So we do want to have all the members of the committee present any recommendations that they may have or any ideas they may have. Please give them to the chair. And we also will be bringing out any recommendations I have to other members too, and we can go through them, and so we can come through recommendations on December the 11th. Thank you everyone for coming. Thank you so much.